too much time because I know we have a whole series of speakers and a lot of technical content to be covered. So I'm going to turn this over, please, for welcome comments to Dr. Lata Venkateshan, the principal of the College of Nursing at AIIMS, who has taken a major, sort of steps in order to put this together. Over to you, Dr. Lata.
Thank you, Kavita. Respected Madam Hekali Zimoni, Joint Secretary of Ministry of Health and Family Welfare, Director of AIIMS, Dr. Randeep Guleria, President of Indian Nursing Council, Dr. T. Dilip Kumar, Ms. Kavita, Technical Advisor to Ministry of Health and Family Welfare, Chairpersons of the program, Dr. Saravjit Kaur, Secretary, Indian Nursing Council, Professor and HOD of Pediatrics, AIIMS, Dr. Ashok Devrari, ADG Nursing, Dr. Rati Balachandran, President of TNI, Dr. Roy K. George, Vice President of ANI, Dr. Jyoti Clara, President of Clinical Nursing Research Society, Dr. Sashi Bala, Ms. Beenama, Senior Manager and Accreditation Coordinator from St. John's, Bangalore, and the Resource Medical Faculty from AIIMS, Dr. Rakesh Lodha, Dr. Rakesh Garg, Dr. Kapil Dev Soni, Dr. Anu Sachdeva, and Nursing Faculty from College of Nursing, Aditi and Mamata, Senior Nursing Officers from AIIMS Hospital, Ms. Matilda, Ambli, Sonia, and Ms. Kiran, dear nurses, students, faculty from various states of the country. It is my honor and pleasure to welcome all of you for the capacity building workshop on rational use of oxygen administration, the nursing perspectives. The second wave of COVID in India made every citizen to value the precious gas of oxygen and the need to conserve it for our survival. Nurses, being the gatekeepers between oxygen therapy prescribed by the doctors and the diligent administration to patients, played a significant role in managing the crisis on the ground reality. No matter COVID may go away or continue to stay with us in different forms, but the best practices need to stay in routine. It is essential to review and standardize the procedures and be prepared to meet the upcoming challenges. I am sure this webinar will provide a platform to discuss and enrich your knowledge. And once again, I welcome all of you for the program. Thank you.
Thank you so much, Dr. Lata. You have played a very important role in a long time now, for the last several months, as we have been putting together all of the modules. As I'm sure you all are aware, I will keep giving general updates during the course of the moderation of this event, just so that all our nurses are in view of the various training and capacity building activities that are going on. It is indeed our honor and pleasure and privilege to have our Joint Secretary for Nursing and Capacity Building and Medical Education, Madam Hekali Zimomi, who has been such a strong gust of wind behind us in the last, literally it's been less than 2 months and she's joined, but we have done so much under her her leadership. And ma'am, we are so privileged to be leading this under you. So thank you, ma'am, and will you please give us a few words of encouragement to the nurses here.
Professor Guleria, Director AIIMS, New Delhi, Professor Ashok Devrari, Dr. Lata Venkateshan, Dr. Dilip Kumar, President INC, Dr. Rati Balachandran, ADG Nursing, Dr. Kavita Narayan, Technical Advisor from the Ministry of Health and Family Welfare, experts and faculty from AIIMS, the state nodal officers, and all nursing students and professionals joining us virtually for the workshop today. Thank you, first of all, for joining us for this capacity building workshop on nursing perspectives related to rational use of oxygen and its management. As we are all aware, the National Oxygen Stewardship Program was launched last month by the Honorable Minister of State, Dr. Bharati Pawar, and this program was developed to build the capacities of our healthcare workers in oxygen management and rational use of oxygen in each facility. As we have seen during the pandemic, adequate and uninterrupted supply of oxygen has been critical in saving lives, and hence the ultimate goal of this initiative is to establish uniform mechanisms in every hospital for judicious use of medical oxygen by training doctors, nurses, and other allied staff. In the December program, when we launched the National Oxygen Stewardship Program, we saw an overwhelming response to the clinical training demonstration that was conducted on oxygen therapy for oxygen stewards. This actually led to the designing and the development of the program that we are launching today. And today's training session on rational use of oxygen as per nursing perspective is conducted so as to inform and upskill our nurses in the use of oxygen therapy. Nurses are the key members of any healthcare team and often the first point of contact for patients and families. More so, patients admitted in hospital are mostly under the care of nurses for the most part of their hospital stay. They are almost always the first to raise an alarm and respond to any change in the patient's condition and responsible for initiating the treatment regime. So there is a need not only to implement training programs specifically for our nurses, but also to expand such capacity building initiatives given the critical role played by nurses in hospitals and beyond. Such enhanced training and continuous professional development for nursing staff will enable a lifelong learning process and set deep foundations for best practices. We all know that nurses account for around half of our total healthcare workers, and this pandemic is a reminder of the critical role that nurses play in our health system. Therefore, it is necessary to have specific training sessions for nursing professionals. Today's session will focus on the aspects related to nursing role in rational use of oxygen, its current oxygen administration practices, and other relevant key nursing responsibilities while handling oxygen. This will ensure that our nurses are skillfully trained in dealing with the challenges related to medical oxygen use. I would also like to mention here that the response to the National Oxygen Stewardship Program has been massive, and training for oxygen stewards has commenced in all states currently. Today, we have more than 9,000 oxygen stewards trained across the country, a small initiative that has led to a very big response from across all healthcare facilities. And I hope that today's session will also be taken up enthusiastically and will help strengthen our nursing workforce in the oxygen management practices. I'm deeply indebted to the leadership at AIIMS, New Delhi, Dr. Guleria and his team, and the Indian Nursing Council for taking the lead in bringing up a session exclusively for nursing professionals. I'm extremely grateful for the support they have extended in designing the technical inputs, training, and the mentoring that has gone into the execution of this important program, and also for providing the resource material for the trainings. Our joint effort, I'm confident, will not only help nurses become more effective in their work, but will also increase patient satisfaction and improve outcomes. I would also like to take this opportunity to thank Dr. Kavita Narayan, our technical advisor, for taking the lead in organizing this program. And last but not the least, I extend my heartfelt gratitude to all of you, each member of the nursing profession, for the commendable service that you have done during these unprecedented times. At a time when the whole nation is united in fighting against COVID, your role is more critical than ever. I wish you all the best, and I hope that this session, this program that we have organized today, will be a very engaging session. Thank you very much.
Thank you so much, ma'am. Thank you. I know that the 4,000 plus people that we have on YouTube right now, more than 6,500 people that we have via the WebEx through the various links, are all extremely grateful and empowered by those words of empowerment that you have shared. Thank you. I think it's very important for them to hear from all the nursing leadership and from the ministry so that they continue to do this yeoman's job. And it's indeed commendable, because there are different people we know. 5 days after COVID, people are getting back, to do what they need to. It is incredible, as really this is the backbone. We have the doctors doing the work, but until you have the backbone for caregiving, which are the nurses who are all out, ready and fully prepared, and we make them empowered as leaders, we will not, really get together either in this pandemic or for the health system. So thank you, ma'am. It is now my pleasure and privilege to call upon and request Dr. Randeep Guleria, who is the director of the All India Institute of Medical Sciences, But besides that, we call him the almanac for, we fondly call him the almanac for COVID. Every time there is a pandemic, everybody goes to him and says, sir, tell us, what's the next wave? How many patients? When will this peak? When will this go up? So he sort of, we always sort of seem to go to him among the other leaders and, keep asking him about what is the next thing. And the country sort of keeps waiting to hear from him. So it would be our privilege to hear from you, Professor Guleria, because your incredible support to get the whole AIIMS team together in developing the modules as well as the dissemination, we are very grateful for. So Professor Guleria, if we could hear from you for a couple of minutes, please. Thank you. Dr. Devrari, has Dr. Guleria been able to join? I see him, I think. He is, I'm going to check on, I thought I saw him and then maybe he's not able to come on. Dr. Devrari, we can't hear you. Can you?
If Dr. Guleria has joined, may I request him to kindly say a few words of wisdom to our nursing colleagues, sir?
I saw him, but then I can't see him now. So I wonder.
So I think he's out of the office. So maybe that is the reason he's not able to have a good connection.
Probably because I saw him and now he's not there. Not to worry, we will keep going on, and then maybe when we see him, we will request him again, sir. We have Dr. Dilip Kumar, the president of the Indian Nursing Council and the leader of sort of this large group of important caregiver group that we have in the country. And he has been quite the force in terms of really enforcing that people are, making sure that the nurses have all been there as part of not just this pandemic, but for, I think, probably the longest reigning chairperson that we know for the Indian Nursing Council. If I can please turn it over to Dr. Dilip Kumar for a couple of brief comments, sir, before we maybe turn it over to the technical sessions. Dr. Dilip, are you able to hear us? I thought I could hear him earlier. Madam Saravjit, I think he could, I don't know if he was, I could hear him earlier I don't know whether he's also having some technical difficulties.
He's just rung up telling there is some technical issue because of which he's unable to hear or speak.
Join also. Okay, not to worry. We will keep going. We hope that whenever they can join, I know the nurses are all waiting to sort of hear. So at whichever point he can join, we will make sure that he can just come on board. Do we see Dr. Guleria there already on screen? Who else is joined on screen along with Dr. Lata? No, I don't see you.
Dr. Lodha,
Dr. Lodha is here. Okay. I think, Dr. Lata, what we can do is, because we have a lot of sessions, we have lots of people waiting, instead of continuing to, we'll just keep going with the session. So I will turn it over to you so that perhaps you can chair this technical session, the next session. And, I'll ask you to please go over with the next set of comments, please. So I think with Dr. Lodha's session, perhaps you can do the introduction of the session and keep moving.
Yes. Thank you very much. Now I invite Dr. Rakesh Lodha, Professor in the Department of Pediatrics, AIIMS, New Delhi, to speak on the topic oxygen therapy in COVID-19. He will be briefly talking about the indications for oxygen therapy, the types of delivery systems, and also the session will be supported by video demonstrations. So over to you, sir.
Okay. Yeah. Thank you, ma'am. So thank you for the opportunity to contribute to this initiative. And as has been highlighted, nurses are the mainstay for providing care, whatever scenario it be it, the wards or the critical care settings. So what I'll do over the next 10 minutes or so is just give you an overview about the indications for oxygen therapy and a little bit about the various delivery interfaces that we have. And this is going to then be followed up by a video session on use of oxygen cylinder, oxygen concentrator, to get an idea of what are the key things that we have to keep in mind. So within next 10 minutes or so, this is all that we're going to cover: indications, types of devices, various types, how we classify, a little bit about monitoring and red flag signs, and a little bit about troubleshooting for some of the interfaces. So who needs oxygen supplementation? So there are two scenarios. In the context of COVID, it's primarily a hypoxic child which means a child whose saturation is less than 94% on room air. And in this setting, our target saturation is to get the SpO2 or saturation that we get by pulse oximeter beyond 94%. What we need to keep in mind is that there would be scenarios where the oxygen saturation is low, as well as the child has excessive distress and increased work of breathing. So in that kind of a setting, we'll need other forms like high flow devices or non-invasive support maybe have to be considered. There would be scenarios where the child has a very high breathing rate, but the saturations are fine. Now, in that scenario, while we may supplement oxygen, this child needs more than oxygen and would need either a high flow device or something like a non-invasive ventilation. And the more sick of them may actually need intubation and mechanical ventilation. Now, just for the sake of completion, there would be certain scenarios where the child's saturation may be fine, doesn't primarily have a respiratory illness, but still we supplement oxygen because the need for oxygen within the body is increased. And this would be congestive cardiac failure, shock state, and at times immediately soon after we extubate, while we are watching the child, we do give some supplemental oxygen. Now, briefly, these are just, this picture shows us the various signs of respiratory distress. There could be flared nostrils, the neck retractions, supraclavicular retractions, lower chest indrawing. There may be a seesaw breathing where when we breathe normally, both the chest and abdominal wall should be moving out. But if this is not happening in this manner, if with the chest wall coming out, the abdomen is going in, or vice versa, then this is a sign of distress. Then there may be certain aspects like noisy breathing, stridor, grunting, audible wheezing, which would be there. So whenever a child is coming in with COVID or has respiratory distress or is in oxygen, we need to monitor the level of consciousness. We need to also monitor the heart rate, respiratory rate, the signs of respiratory distress, and oxygen saturation. Now, briefly, what are the various types of devices that we have for oxygen therapy? So it could be a nasal cannula, where the flow rate would be about 1 to 4 liters. That's what we typically give. Beyond that, it would not be comfortable for the patient. This provides a slight increase in the FiO2 to about 24 to 36%. And what we also need to have an idea that if we have a cylinder, then in that kind of a setting, a D-type cylinder, then this is likely to run for 30 to 60 hours if the flow rate is 2 to 4 liters per minute. So if it's 2 liters, then about 60 hours, 4 liters, it would be over in about 30 hours. So that's important to plan how many cylinders you need or when you need a replenishment. A simple face mask, the FiO2 delivered is dependent on the flow rates. So it could be about 40% when the flow rate is 5 to 6 liters per minute, and it could rise up to 60% with 7 to 8 liters per minute. And correspondingly, this particular chart shows how many hours a D-type cylinder is likely to last. Then when we want to, there are times when we want to give a higher concentration. So in that scenario, we use a mask with a reservoir bag or a partial rebreathing mask where the saturations can go upwards of 60% to 90%. And then there is a high oxygen concentration mask, or what is called as a non-rebreathing mask, which essentially means that there's a reservoir, there's a one-way valve, and the oxygen, which is 100% oxygen, which is there in the reservoir, is going to come out only during inspiration, and therefore at a high flow of 8 to 10 liters per minute, it gives you a FiO2 of up to 100%. So if we want to have a patient who needs a high concentration of oxygen, then this is what we could use. But at the same time, we need to keep in mind that if the child is having very labored breathing, work of breathing is very high, then just oxygen may not be sufficient. We need to escalate therapy to either a high flow device like a high flow nasal cannula, or go on to other forms of support like non-invasive mechanical ventilation or intubation and mechanical ventilation. So this we have already talked about, that we need to monitor both the patient. So we're going to look at it, in a sick child, early monitoring of level of consciousness, heart rate, respiratory rate, signs of respiratory distress and oxygen saturation. At the same time, we also need to monitor the device or the equipment. So we need to keep a watch on the oxygen flow rate, patency of the tubings, watching for any leaks. And if there is any humidification, then we need to make sure that the humidifier bottle has appropriate level of sterile water, is something that we need to keep in mind. So one could be using a chart like this, and this has been shared in various guidelines. It just tells us at a glance, we can look at whether the child is the condition is improving or there is any deterioration, and accordingly the physician may be informed about the next steps. So in the monitoring, the key things are we need to maintain normoxemia, and we did talk about that. We need to have the oxygen target maybe 94 to 96% or so. In severe areas, you could have a lower saturation target of 88 to 92%. We need to avoid both hyperoxia and hypoxia. So 100% is not always good, and particularly in context of oxygen, we don't need to target 100%. High oxygen saturation, if it's there, then obviously it's leading to oxygen wastage. But what we also need to keep in mind is that high oxygen can also lead to lung injury. Now, this aspect is not very well recognized. Most of the people who work with children and newborns would know that very preterm babies, if they get high oxygen concentration, they are likely to develop a condition called retinopathy of prematurity, which can cause blindness. So there, I think there's still a lot of awareness, but older children and adults, people at times miss this out, and we need to be worried that there could be oxygen-mediated lung injury as well. And obviously, we don't want low saturation, which is going to lead to tissue hypoxemia. And if that is associated with a low blood pressure, then there is ischemia as well. The red flags that we need to when we monitor, so obviously a child who develops altered sensorium either gets drowsy or gets agitated, we need to be worried. Increase in respiratory rate or work of breathing or saturations dropping to less than 92% despite optimal device flow settings is a cause for concern. Child developing tachycardia, marked pallor, cool peripheries or feeble pulses or fall in blood pressure, that's certainly a danger sign. And as in when we feel that the airway is threatened, which means that there is either stridor, there may be unconsciousness, and therefore the protective reflexes are compromised in child's ability to cough or having a gag that is affected, and therefore the child would be at risk for aspiration. Similarly, secretions, blood, vomitus accumulation again predisposes for airway compromise. So again, just to re-emphasize, low flow devices help with oxygenation but not ventilation, and CO2 retention, fatigue, respiratory muscle fatigue can still occur. And in that setting, we need to decide that at what point in time oxygen therapy alone is not sufficient and we need to escalate therapy. So this is just a recap about the low flow devices. Typically, what we choose may give you FiO2 of 25%, in some scenarios up to 90%, but that's typically with high flow non-rebreathing mask. Regular monitoring is critical. We need oxygen saturation targets of up to 96%, avoid both hyperoxia and hypoxia. We need to have appropriate fit of the low flow devices to ensure adequate supply and prevent leakages and wastage of oxygen. And in addition to monitoring the patient, one also has to monitor the devices or equipment which has been used to deliver the oxygen. Just a couple of slides on the basic troubleshooting. So we need to make sure that the mask is fitting well. One should tighten the nose clip, which is a metal clip, and the head straps should be tightened up. The upper end of the mask should sit on the bridge of the nose. The prongs, we need to keep in mind that they should be proper size. They should not fill more than 50% of the nostril. Children at times may just want to get rid of it, and therefore they may dislodge it. So just secure it with a proper or whatever minimum adhesive tape that we can use on the cheek. And at the same time, we need to have a gap from the nasal columella to avoid trauma. So otherwise, if the prongs are too tightly fitted close to the columella, there would be pressure on the skin, and that may lead to some necrosis, discoloration, and blackening, which may happen. Then we also need to keep in mind the leaks and obstructions. So many of us may take this for granted that this is not our job. But the issue is that if we figure out there's a leak, we need to make sure that the leak is taken care of. Otherwise, we are going to waste a lot of oxygen. You need to check the tubings and connections. There would be times when, there would be some times when children or older children are breathing by mouth with nasal prongs. And in that scenario, again, the delivery of oxygen is going to be compromised. And therefore, in that setting, you modify it. Similarly, you need to check for regularly for nasal secretions and obstruction, patency of nasal prongs. If you have a humidifier, then make sure that the water level is appropriate and there is bubbling which is happening, and this would be demonstrated in the video. Make sure that if you're using a humidifier, the washers are in place so that there's no leakage that is happening. and the connections are all tight and there's no leakage happening there. And move to the next. It's not moving. Yeah. So to sum up, we have various low flow devices like nasal prongs, face mask. Then you have others like non-rebreathing mask, which just comes under category which many people would consider as high flow. The other devices are going to be talked later are high flow nasal cannula, where the flow rates go up to 2 liters per kg per minute. And then we need to keep in mind that a lot of these would be considered as aerosol generating. So wherever possible, so if an older child can tolerate a mask, it may be good to apply even a surgical mask which covers the face and the nose. Regular monitoring is critical, not just of the patient, but also of the devices to make sure there are no leakages, no wastage of oxygen. Appropriate use of humidifiers. And again, saturation targets may be there, again, 92 to 96% to avoid both hyperoxia and hypoxia. In very sick children with ARDS, we lower the saturation targets to 88 to 92%. So with this, I'll end this particular session, and we could go on to the video, which is going to tell us about the first video, please.
Opening the cylinder.
Oxygen therapy is also very important to understand. Oxygen makes things burn more easily. Following safety guidelines is very important.
Dr. Lata, can we request you to please turn up the volume of the video? At least I am not able to hear it too loudly. Perhaps the others are also having an issue.
We should check for any.
We are increasing the volume.
Thank you.
We should put it and everyone can. Next one is we should keep the oxygen tank in ventilated spaces and not in. And we should also keep the oxygen tank, that is the cylinder, away from any heat sources. Fire, stove, matches, and even the light.
Still not able to hear clearly, ma'am.
We should never use them. Let me show you the parts of the cylinder. And now let me explain to you the different parts of the cylinder. We have the valve.
Still not able to hear clearly,
Well,
ma'am.
we also have the flow. And this is the help us with
I think YouTube.
This is the
YouTube volume.
which can also help us to know the amount of oxygen.
Just a quick note to all the participants on YouTube who are possibly not able to, in fact, even on WebEx, ma'am, we're not able to hear it. We will share the link of the whole video to on YouTube as well, on the link, and also to all the participants right after. So I think that will be the best way for you to see the video on your own even after this session. And in the meanwhile, they're just checking to increase the volume.
Very important you should remember is that before you open the valve, make sure that it's not closed tight. Because if this is not closed tightly, what will happen is that the oxygen will flow at a very high rate.
No, they have to put the YouTube.
Now, how do we open the flow meter? In order to open the flow meter, we have to rotate it slowly in clockwise position. Now, this ball will indicate the amount of oxygen which is being delivered to the patients. Like, for example, now it is 4. The ball falls at 4. Now, it means that the patient is getting 4 liters of oxygen. In order to close it, we have to rotate it until it clockwise. Now, this ball, now coming to the humidifier, this is a humidifier because it's connected. What you have to do is you have to clockwise motion. Once you open the humidifier, you can see that there is a markation of minimum and maximum. So the amount of water to be distilled is between the minimum. Another important point which you should remember is that in hospital setting, you can put distilled water or sterile water. And at home, since distilled water or sterile waters are not available, you can use a simple RO water, but make sure that you change it back. Now I will show you how to put it back. In order to put it back, you have to just fix it and then rotate it in the anti-clockwise positions. And make sure that it is tightly fixed so that the water doesn't spill out.
Yeah. Yeah. So the part 2 video is on non-rebreathing mask.
Mask is used to provide high concentrations of oxygen to a spontaneously breathing patient. And it is called non-rebreathing because it does not allow rebreathing of the exhaled air. So it's also a disposable plastic mask. It has a similar nose clip and an elastic cord. The extra features in this mask is a reservoir bag which is attached to the oxygen supply. This bag will be filled with 100% oxygen when we connect the tubing to the oxygen supply. It also has one-way valves. Now there are one-way valves on either side of the mask. These valves allow the exhaled air to go out, but it will not allow the inhaled air to get inhaled when the patient is breathing in. This valve that is there between the mask and the reservoir, this will allow 100% oxygen from the reservoir bag to come to the patient when the patient is inhaled, but it will not allow the exhaled air to go from the patient to the reservoir bag. Hence, it is a non-rebreathing mask. So before we attach the mask to the patient, we should ensure that the reservoir bag is completely getting filled up and there are no leaks. So we should connect the oxygen tubing and we should use a minimum flow rate of 8 to 10 liters per minute when we are using a non-rebreather mask. We should upload this valve and allow the reservoir to completely fill up. Then we should squeeze the reservoir, ensure that this valve is functioning well. Once again, after filling up the reservoir completely, we should then attach the non-rebreather mask to the patient. Now, when the patient is breathing in, the reservoir should be deflated by about 1/3 with each breath. We have to ensure that the reservoir does not get completely collapsed when the patient is breathing in. The caution to be used with a non-rebreather mask is that if there is oxygen supply failure or if there is any leakage, there could be suffocation because the patient is not getting any ambient air. These valves are not allowing inhalation of ambient air. All the oxygen that the patient is getting is through the bag. We have to keep watching the bag and watching the patient that the bag should not be completely collapsed and there should be no failure of the external oxygen supply. So close monitoring of the patient on non-rebreathing mask is very important. The FiO2 that is provided by a non-rebreather mask is very high. It can go up from 80% to 95% also.
Not hearing.
Another device that is available. Venturi device bag. There are two kinds of venturi devices. One is a very adjustable flow. There are markings on this which can give you different markings provided by and the also on this device. It helps us to provide fixed FiO2. We can fix it at 24%, 26%, 28%, 21%, and so on. There are another type of devices which are color coded. So these devices are fixed and color coded. So each of these will mention the FiO2 and the flow. For example, this red one mentions 40% FiO2, 10 liters. So when we are using this, we should use 10 liters of oxygen and it will provide us 40% of FiO2. Similarly, this one will we have to use 8 liters and it will provide us 35% of FiO2 and so on. So these are color coded ones. And this is a variable adjustable device. The extra advantage is what happens is there is a small there's a nozzle here which is a very small opening. It will generate a high negative pressure which will lead to entrainment of ambient air and the patient is breathing in through these holes. the flows provided by this device are very high. That is why it is classified as a high flow device. So the advantages is one, it provides a fixed FiO2. You can also taper the patient because we can taper the FiO2 as per this, as well as it helps us to give high flows using ambient air, so less oxygen is wasted. As it has been emphasized again and again, we should continuously monitor the patient who is on oxygen therapy. We should try to wean the patient off as early as possible to prevent both oxygen toxicity to the patient as well as to avoid wastage of medical oxygen. Thank you. Now I will hand over to Dr. Kapil for demonstration of high flow nasal tube.
I'll be demonstrating about the oxygen concentrator. So oxygen concentrator, which uses the atmospheric air. So atmospheric air will be sucked in from this inlet port, and in this there are zeolite crystals which will absorb the nitrogen, and then the oxygen, which is around 90 to 95% concentrated, it will come out through this oxygen outlet. So briefly, I'll tell you about what are the controls on the machine. So what we see here is it's a flow meter. Here it is from 1 to 5 liter per minute. Some of the machines it can be up to 10 liter per minute also. This is the outlet for the oxygen. This is a reset button, and this is this displays the hours for which the machine has been used. And on the back side, there is a recess for attaching a humidifier water. So the oxygen from here goes into the humidifier water, and from the humidifier water, it will go into the nasal prong or face mask line that they are using and to the patient. Now I'll just switch it on and I will show you how it operates. So we have connected it to the electricity, and now I'm switching on this button. Once you switch on, it gives a alarm, which is for low oxygen alarm, but within 1 to 2 minutes, this alarm will disappear because the oxygen concentrator will rise above the lower limit, which is around 80% for this machine. And then we are going to open this flow meter to the desired flow. So here it can go up to 5 liter per minute. And we can see here that there is problem in the humidifier water, and this can be applied to the patient whoever needs oxygen. So traditionally it is used for chronic care or home oxygen support, but it can be used even in acute care when the facilities are not available. Limitations are that it has a limitation of flow, so maximum in some machine it can go up to 10, but it is usually the flow is up to 5. So it can be used with the face mask or a venturi mask or a nasal prong, but it cannot be used with the non-rebreathing. Little bit about the maintenance. So the maintenance includes the cleaning of the external cleaning of the machine, cleaning of the humidifier water, and cleaning of the nasal prong. It should be done regularly, usually once a week for the machine and the tubings of nasal prong, and almost daily the water should be changed or as per when required. And the cleaning of the filter that has to be done as per the manufacturer.
People are not able to hear.
Dr. Lata, my recommendation is that the videos are not being audible at all. So we may perhaps save some time by, just sending them the video links directly, and maybe we can do the actual sessions of the presenters, because nobody can hear anything, I think, either on YouTube or on this. So since we have the, proper files, we can just share it with everybody and they can look at it. It might just save us some more time. Otherwise, they're only looking at it and not really, hearing anything.
Yeah. Actually, in YouTube, we were able to hear.
It's okay.
Yeah, it is okay. We will move on to the next session. Any questions from the participants?
Rakesh, there is a question for you. how a typical prescription for oxygen is written. Oxygen is a drug, life-saving drug. So if a medical officer or a nurse is writing a prescription to be followed, how the prescription is written?
Okay. So I think the basic principles of prescription writing in terms of the patient who has to get it, the details of that. We need to have the diagnosis in place. We need to write down about the time when this prescription is written. And we would need to mention the device by which we are giving the oxygen, as well as the flow rate that has to be done. And accordingly, one would do this, and also the monitoring aspects, the monitoring chart as to what all has to be done, and also try and indicate, particularly if, let's say, the staff is monitoring as to what the danger signs are and in which scenario the physician should be sought. So it could be, let's say, a child who's receiving oxygen by nasal prongs, 2 liters per minute. And along with that, we would say monitoring of clinical signs, heart rate, respiratory distress, level of consciousness, the oxygen saturation every 1 hour. If the saturation is less than, if it's dropping below 92%, or there is child has excessive distress, or becomes agitated or drowsy, or the heart rate increases, let's say in this scenario, let's say it goes beyond 140, in that scenario, they should be calling for a physician to look at the child and also look at as to what the next steps would be. So it would be similar to what we write for any other prescription, which should duly be written and signed by the person who's writing the prescription.
Thank you, Rakesh. So I think you highlighted all the points. Oxygen is like a drug. Too much or too little is bad. So you also write down, in addition to whatever you mentioned, when do you de-escalate oxygen so that you prevent hyperoxia in the patient. Rakesh, there is another second question for you. Can we use oxygen hood box for giving oxygen for infants below 1 year of age?
Yeah, so there would be, in terms of an oxygen hood, it's a plastic transparent hood which would be placed over the child's head and neck, and we would have an oxygen inlet, which is typically the flow rates that we need to use are on the higher side. That is important to make sure that there's adequate gas flow within the system, and whatever CO2 may be accumulating with the child breathing out, that should not get trapped there. So typically these devices would be, you would have to have a flow rate of 4 to 5 liters per minute. But in a child who's not tolerating prongs, certainly this would be an option to consider.
Yes, thank you, Rakesh. So better is to use nasal prongs, as you rightly said, because the oxygen wastage also will be much less. But if child is not tolerating that, you don't have any option but to use oxygen hood. Over to Lata for the next presentation.
Yeah.
Lata?
Yes, sir. Thank you, sir, for that very detailed presentation. Now over to Dr. Rati Balachandran, ADG Nursing from Ministry of Health and Family Welfare, to chair the session on oxygen monitoring by Dr. Rakesh Gar.
Thank you, Madam Lata. Good afternoon, dignitaries, experts, and dear participants. We are passing through the tough times following COVID pandemic. And I pay tribute to all the healthcare professionals who have paid their ultimate sacrifice in this battle. Because of the dedicated, competent efforts of all healthcare professionals, especially nurses, we could save many lives. And as we have seen, that oxygen is necessary for survival. And during COVID, the oxygen supply to the body is affected. And we are checking the oxygen saturation. During the second wave, it becomes more and more crucial, and people were running from pillar to post for getting this oxygen supply. Oxygen is life-saving medications, and it is to be ensured. It has to be provided rationally. If it is less and or if it is more, it affects the health. So today we have Dr. Rakesh Garg, Additional Professor, Department of Anesthesiology of AIIMS, New Delhi, to update us about the oxygen monitoring, identification of the danger signs of low oxygen level, when to start oxygen and when to stop oxygen therapy. Nurses being the custodian have to be updated with these steps, and the people will be feeling safe when they are in the hands of competent nurses. So over to you, Dr. Rakesh Garg, for updating the nurses and empowering them about the new advancements and the points to be observed. Thank you.
Thank you so much, ma'am. So we'll take you in continuation what we have just seen in pediatric patients. Let's see which are the devices are available to us, which we can take on for monitoring the oxygen of a particular patient, and what are the clinical things, and how can we go from one to other. The question was just being asked that how to wean off. Oxygen is a drug, so we have to use it very, very judiciously so that the patients are not devoid of it. And also, we are not wasting it. Least to talk of the oxygen toxicity, but oxygen being a resource, a judicious resource, we should be careful about using it. So let's talk about the oxygen monitoring. And by the end of this session, you will be able to understand what are the monitoring devices available to us. How can we identify the signs and symptoms of low oxygen? And what are the methods? How can we escalate the oxygen therapy from our gadget to the different gadget? And how can we wean off if the patient starts responding? Having said that, yes, definitely there is no reason for us not to follow these do's and don'ts for COVID prevention. But we need to understand that in the journey of this COVID infection, there will be phases wherein the oxygen saturation may start coming down. So it will depend upon the stage of the disease. Some patients will start responding. If you see the third wave, probably the virulence of the disease is a little different as compared to the first and second wave. But then we need to monitor these patients to capture them at the earliest so that we can initiate the treatment timely for these patients. Now, when we talk about the monitoring tools, there are two important aspects. One is definitely the clinical parameters. And second is we can use some monitoring tool or equipments. Now, clinical symptomatology, if you see the patient of COVID, it is affecting almost all the body systems. And when we talk about the oxygen requirement, it is just not the pulmonary aspect, but it is also related to the effect on the other organs also, like, for example, cardiovascular system or other secondary infections. So we should be a little cautious when we are seeing these patients for the oxygen supplementation, that we are looking for the pulmonary aspect, but simultaneously the other things also needs to be looked for. Also, the presence of these symptoms would depend upon patient's age, the presence of disease process, the level of health, and the presence of chronic illnesses. That's why we are saying that those patients who are having high comorbidities, those patients who are having respiratory disease, pre-existing respiratory disease, they will have probably earlier signs of low oxygen because their reserves are low, and hence we should be a little cautious with this. Now we have to identify the signs and symptoms at the earliest. I think the nursing professionals are the lead. They are the main ground level person who are looking at these patients round the clock. So we need to identify the signs and symptoms of low oxygen at the earliest, which includes shortness of breath. Patient will be feeling a little discomfort. It may also be in the form of some compensation, which initially leads to increase in the respiratory rate. Also, subsequently, they could be the bluish discoloration of lips, skin, or mucous membranes. And also, patient probably, when they become hypoxic, they tend to make a sitting position, leaning forward. If you try to talk to them, they will not be able to speak complete sentences. So these are the telltale signs that patient is having short of breath, patient is having low oxygen. And as the hypoxia worsens, the patient can show hemodynamic response also. There could be initial tachycardia followed by bradycardia. There could be hypotension. There could be active heat intolerance. The level of consciousness starts decreasing. So this is how the gradation of falling oxygen levels can be picked up in case we are following these patients. But remember, the earlier signs of hypoxia usually manifest in the form of anxiety, confusion, sweating. Sweating is more commonly seen in this third wave of COVID-19 infection. They start compensating for it. But if the patient becomes more confused, they are delirious, the hemodynamic response happens, the cyanosis starts happening, patient starts losing consciousness. These are the critical signs. We don't have to wait for these critical signs. We have to identify them early so that we can initiate the oxygen therapy, because if the oxygen level goes down for a longer duration, the cascade inside the body starts happening, the organ failure starts happening, and hence it becomes important to identify them early. Having said that, We also need to understand this term happy hypoxia. We have seen many patients who would show a saturation of 75, 80, 85%, but they were looking very well. They were a little anxious, but they were not showing other features which I've just mentioned. So this is a quite characteristic of this coronavirus infection in this phase, and hence we should be a little cautious, and hence it requires supplementation of a monitoring tool for these patients so that we can monitor them, those who are COVID-19 positive. Basic tools that are available for in-hospital are pulse oximetry and arterial blood gas test. Pulse oximetry has become a very, very important tool, not only for inside the hospital, but also outside the hospital, and hence it becomes essential that we understand the nitty-gritty of using the pulse oximeter appropriately. You must have seen in the first and second wave, there were a lot of news that pulse oximeter was showing reading without being attached to the patient. It was not showing appropriate reading. So this means we need to understand ourselves also, and also we need to teach the patients and the caregivers so that they can monitor the pulse oximetry appropriately. Also, we need to understand just not the patient's oxygen saturation, but as we just mentioned, and Dr. Lodha also mentioned, that oxygen is a drug. So we also have to monitor the oxygen being delivered using oxygen delivery devices, and hence the selection of device needs to be done appropriately depending upon the situations. ये hang कर गया? So when we say the pulse oximetry, it is a non-invasive method of measuring saturation, and pulse oximeter is a device. So this is the term that we use for them. And now this is the commonest monitor that you must have seen. Inside the hospital, outside the hospital, this is a finger probe that has been used. But now inside the hospital, we usually have a machine-based pulse oximeter where it is a console attached to a cable and a probe is attached to the patient. So this has a probe, a cable, and a console when we talk about the pulse oximeter. Inside the hospital, yes, this assembly is there. Outside the hospital, we usually use a finger probe that is usually available. Now, which are the sites for application of these type of probes? Usually the most conventional site is the fingertip. You must have seen it that majority of time it will be on an index finger or a middle finger. So because the failure rate is less, the performance is good, even in case of a poor perfusion. So try to apply on a fingertip. But depending upon the size of the probe versus the size of the finger, sometimes if it is not fitting well, it will give RNS reading. And hence, it sometimes can be applied to other parts like toes. For example, if you are using an adult probe or a bigger probe to a smaller child, in those cases, you can use the toe also. There are other types of probe are available which can be attached to the hyperthinner eminences. That is your the hand part. It can be applied to cheek, earlobe, and it depends upon basically the need of that particular person. So start with finger trim in majority of patients, but those who are critically ill patients, those who have low perfusion, probably these patients may not show a good sine wave or good saturation readings when you apply them on the finger probe. Right. So when you apply this pulse oximeter to these patients, remember, these are the key points that you need to remember, that the sensor application should be appropriate. That is, whatever the probe that you are using should be okay. You see there will be a red light and there will be a small window on the other side. So the position of this LED and photodetector should be appropriately placed so that the finger comes in between. There is a good skin contact. There is proper application site and preparation, that it should not be wet, it should not be having a nail polish, it should not be colored. There should be a reduced activity level so that this means the finger is not moving. If there is an artifact, there is a movement of the finger, it will show an RNS reading. Protection from the environment light. If there is a lot of light falling on the probe, it will show again an RNS reading, and use an appropriate size of the sensor. So now when you apply it, this is for us to understand, also to make the caregivers understanding. When you apply them, let it apply it for a couple of seconds and take the readings at least at a time 2 to 5 minutes when it's stabilized. Let the hand rest on the chest at the level of heart rather than dangling in the air. Check that the displayed heart rate correlates to a manually checked heart rate. This is important because most of these pulse oximeter will also show a heart rate. If there's a discrepancy between the heart rate on the pulse oximeter, on the manual pulse rate, this means the reading is not acceptable. The reading is RNS. And hence, when you start initiating the application of pulse oximeter at least once, maybe when you are having any confusion, just measure the pulse rate of the patient and correlate. If it is yes, then probably whatever the reading is acceptable. Ammeters and the detectors must oppose. If you see the pulse oximeter, the red light and the detector, they should be across the finger. They should not be directly reaching, and that will be the appropriate light, and use appropriate size probes. In case sometimes you will see that when you apply the pulse oximeter, the readings will fluctuate. You will see it's showing 97, but then it will show 85 and then will come back. This means probably patient will not show usually clinically so much of fluctuation without intervention. So this means this is a technical error. In those cases, ensure that the patient finger is warm. You can rub the skin. Try an alternate probe site. You can keep on the other hand. You can keep on the foot also. Try a different probe and check your equipment also. Especially the finger probe, they are very sensitive. If you just make them fall 1 or 2 times, the internal settings will go up, they go haywire, and probably they will not show the correct reading. And there are a couple of situations in which you should be cautious. Emotion artifact. Sometimes the patient may be shivering because they may have fever. In those situations, whenever the movement of the finger happens on which you have applied the probe, they may show a different wrong RNS reading. So always you need to be cautious about it. The application of nail polish, it will again, especially when it is brown, red, blue, black, or green, in those situations, it will again go wrong readings. Either remove them or apply at different places. Low perfusion, especially when they have hemodynamic issues. In those situations, probably the pulse oximeter, especially the finger probe, when we use in the hospital setting, they have some technology that can pick up low perfusion pulse oximeters. But then in those situations, when you're using the finger probe, they may show RNS reading. So you can change it to the central site, or you can apply some vasodilating cream or digital nerve block. We do it. And probably the most commoner, the remedy will be warming the patient, warming the finger. You can just apply a cotton pad over it. It will warm up and will show a good reading onto it. The edema. Sometimes these patients, especially who are critically ill, especially those nursing professionals who are taking care of these patients in the ICU setup, they should be cautious, because if it is an edematous hand, then it will show an RNS reading. Optical interference, too much of glare of the light. In those situations, again, they will show an incorrect reading. Now, this is just a step. I may not be going into detail. It will be with you. These slides will be with you also. You can just go through it. These are the steps that you can always learn yourself. You can paste it somewhere, and you can tell the caregivers also, because sometimes the caregivers, when they are using finger probe, they will be taking correctly. Just turn the pulse oximeter on. It will take some time for internal calibration. For that time, whatever the readings are coming, there may not be appropriate. Just wait for a couple of seconds. When these readings stabilize, then you can use them. Select the appropriate size of probe. Connect the probe to the pulse oximeter. Position the probe carefully. It fits appropriately on the finger in which you are applying it. It is easier to loose, not too tight. If possible, avoid the arm used for blood pressure monitoring, because when you take the blood pressure through the same arm, it will the perfusion will stop, and the artifacts will come up, and it will happen quite frequently. So try to avoid it. Allow several seconds of pulse oximeter to detect the pulse and calculate the oxygen saturation. Look for the displayed pulse indicator. Each machine will have some signages. It will be like an wave which is coming and going back. Look for this. If it is going appropriately, then probably the readings are acceptable. If there is no pulse signal, then probably it's an artifact. So you be cautious of measuring these readings. Like all machines, pulse oximeters may give a false reading. If any doubt, look for the clinical judgment. Look for the other parameters. Look for sometimes, especially when you're on a critical care setup, we can also look for the ABG, especially for critically ill patients. But otherwise, look for the clinical parameters if they're in the ward. First, the function of oximeter probe can be checked by placing it on your own finger, because you know that your saturation is okay. So that will be a self-testing. Adjust the volume of audible pulse peep. Now, this is important, especially when you are inside the hospital setting. Each of the pulse oximeter has a alarm setting. So please set it up, because in case if the patient deteriorates, the alarm can warn you up that the saturation is falling or the pulse is falling, and you can take appropriate action. Now next is the initiation of therapy and the weaning of the therapy. We have to use it very rationally. So what we say is, when we start the oxygen, the target should be somewhere between 94 to 95%. In case if a patient is of COPD, of a respiratory disease, then don't target such a higher level. Probably 88 to 92% should be okay. In case if you are using other devices, the BiPAP should be preferred over HFNC, and you can take an individual decision depending upon the patient situation. Also try to individualize the oxygen therapy depending upon the patient's clinical status. There is nothing called the dose for a particular patient. You have to individualize it based on the clinical parameters. based on the patient response to initiation of the oxygen therapy, and then try to wean it off as early as possible. Triage the patient as per their oxygen status, because each ward where you are managing the patients, they may have the oxygen outlet on the wall. There could be HFNC, there could be requirement of the BiPAP. So this means you need to triage the patient so that they can be taken care of. The patient who are on oxygen therapy should be reviewed regularly to evaluate the oxygen requirement so that you can wean them off earlier. And that's why regular training of your colleagues, your OT technicians should be okay. Now, this is how you can know up titrate or low titrate depending upon the patient response. We have already have a target saturation for us, maybe 94%. And based on this, you can think of which device will be appropriate. These devices will be discussing in the subsequent session in detail, but this is how you can escalate or de-escalate once you achieve the target oxygen saturation. For example, if a patient was showing a saturation of 90%, you started the patient on reservoir mask at 15 liters, and the saturation starts improving and it has reached say 98, 99%, and it is stabilized now. Patient is stable. Now this is time you can wean you off, and you can think of that which will be the appropriate devices where you can downgrade the oxygen supplementation to these patients and you can use them. Similarly, if you want to escalate, you can use these devices. It was just in one of the video, you can see how to use this device and you can use them. So this is how at times when the patient is clinically stable, you may require to escalate it or de-escalate depending upon the patient response of your treatment. If a patient is deteriorating, probably the devices that I just mentioned about nasal prongs or non-rebreathing mask, you can supplement them with HFNC or non-invasive ventilation. And then you can even at times may require supplementation of mechanical ventilation. But remember that other modalities, like for example, when you are supplementing them with oxygen therapy, you should also remember that the oxygen requirement may also change if you start initiating other therapies. And prone positioning is one of the therapy which has give a lot of impetus to bring down the oxygen requirement of these patients. So all conscious patient, awake patients, you can always counsel them. You can also encourage them to be in a prone position so that they can be brought down with the oxygen requirement. Continue with all the things, specifically the chest physiotherapy. Now, this is an important aspect for oxygen supplementation when you are weaning off. The oxygen may be, the lungs may be affected, and chest physiotherapy has been found to be a good modality to increase the or recruit the lungs function, and hence it should be included as a part of your management. Continue all the supportive therapies of this patient. Try to keep the patient's head and elevation, and other requirements as per the patient needs to be continued. As I mentioned in the beginning, that oxygen is just not the function of the lungs. Oxygen requirement is just not the function of lungs, but other system would also alter the need of the oxygen supplementation. And hence, we need to treat the patient holistically. So to summarize, with regards to the oxygen therapy, the monitoring equipments, know your equipment well for oxygen level monitoring, which equipment you are using, what could be the concerns when you are using this equipment. The equipment that you are using is actually giving the right value, you should accept it, or you should have some remedial measures. Identify and timely initiate the oxygen therapy. Once patient is stabilized, try to wean them off and appropriately so that you are not wasting the oxygen. And oxygen is a drug, use it judiciously. Thank you so much.
Thank you, Dr. Rakesh, for giving a detailed description about the signs and symptoms and how to use the pulse oximeter effectively, and all the practical tips which you have mentioned is very useful for the nurses. Is there any question for Dr. Garg? I could not see any Q&A questions.
Yeah. Madam, actually, there are two questions. Probably Dr. Lodha or Dr. Rakesh Garg can address. How long can we store oxygen in cylinder type A, B, and D?
I think this was discussed earlier also. The oxygen does not have an expiry as such. So whatever the oxygen is stored in the cylinders and appropriately stored, it can be used without much expiry. Only thing is the cylinder should be stored appropriately. Sometimes if not stored, there can be a leakage of oxygen. So you think that your cylinder is full, but after some time you will find it empty. So be cautious that it is not leaking, it is appropriately placed, the tip is not damaged so that you can use it as and when required. So there is no as such expiry for particular oxygen stored in the cylinders.
Yeah, I think I would agree with that. And while some companies may put up a label, and which is generally 2 to 3 years, but the key thing is that while being stored, if there is a leak, there's a problem. A cylinder which has been opened once and used partly, I think one needs to make sure periodically check whether it has adequate pressure, and that should be about 140 to 150 kilogram force per centimeter square. Only then it's likely to have the requisite amount of oxygen. Otherwise, we may think we have a cylinder, but if it doesn't have oxygen, that's actually quite dangerous.
Rakesh, the cylinders which are empty should be labeled and kept separately, not
Yes,
with
sir.
the cylinders which are filled cylinders.
So yes, sir. So the new cylinders that come in actually have a seal on the their outlet, and if the seal is removed, obviously that's the reason that one would need to be careful that these should not be mixed up, and one shouldn't think that we just have a cylinder. Therefore, part of the monitoring and daily checks that a unit should be doing is to look at whether the cylinder that they have is at least one cylinder which is full, particularly for transport and all. For areas which are relying primarily on cylinders to deliver the oxygen, I think they need to have a adequate inventory to make sure that there is adequate amount of oxygen cylinders which are full, which are available with them. So.
Thank you, sir. The next question is, what device will be good for the newborn baby?
So the oxygen devices, if you're looking at newborn babies, we may use if you have appropriate size prongs. And I'm not at this time point, I'm not talking about very like preterm babies and all. And again, I think this topic is going to be covered by Dr. Anu in a little while. The option is to use oxygen hood is what. So prongs or oxygen hood is what we may be looking at. If the child has excessive distress, then non-invasive modalities like giving nasal CPAP or bubble CPAP is something that is very commonly used in newborn setting.
Thank you, sir. I think
Thank you.
Those were the two questions.
Yeah. Thank you, Dr. Rakesh Garg and Dr. Rakesh Lodha. A competent, vigilant nurse can save life of many who are there, and being the custodians, as I mentioned earlier, the life of patients have to be saved by competent nurse, by vigilant observation. Moreover, they have to also ensure that there is oxygen is available if there is any need arises. So as mentioned, the inventory has to be also ensured. And with this, I request the participants to utilize this knowledge in your daily practice and also stay tuned for the further sessions. Over to you, ma'am.
Thank you, Dr.
Thank you.
for the excellent session. Now we move on to the next session, and I request Dr. Sarabjit Kaur, Secretary of Indian Nursing Council, to chair the session on oxygen audit.
Thank you, Dr. Lata. Am I audible?
Dr. Lata and Dr. Sarabjit, if you can just ensure to keep your volume at max. We are just hearing some comments from people saying that they would like the audio to be a little bit louder. So if you could just keep your volume at max, please. Thank you.
Thank you, Madam Kavita. Am I audible now?
Yes.
So once again, good afternoon, Dr. Deorari, Madam Rati, Madam Kavita, and all those who have assembled here. This is a very important session that we're going to have now. As nurses or as nursing officers, we are all very used to stepping up into our workplace and first and foremost taking stock of the situation, our inventory where we are working. And this just now it has been brought out. It also includes the oxygen part where we see, do we have the oxygen cylinders? Are they filled? Are they empty? We check the pipelines, checking the circuits for leaks, stocking the right kind of masks, the flow meters, and the entire gambit. And this is all very, very important part of oxygen audit. Today to talk about this, the emergency oxygen therapy, oxygen conservation, and the prevention of hypoxemia, we have two very important people with us. We have Dr. Sanjeev Bhoi, Professor, Emergency Medicine from AIIMS, and Mrs. Sonia Chauhan, the Senior Nursing Officer from Trauma Center, AIIMS. I hand over to Dr. Sanjeev to please speak about this.
Thank you, Madam Sarvajit Kaur, and to the nursing fraternity, who is, along with Ministry of Health, who is organizing this very important topic on oxygen therapy, on the length and breadth of the various paradigms of oxygen therapy. So we're just sharing the screen just now. Is the screen visible, Madam?
Yes, we can see it.
Yeah. Can you hear me loud and clear?
You're audible. Please go ahead.
A little bit louder, please. Again, request you to just speak really loud and also turn up the volume on your mics. Thank you.
Okay, thank you. Thank you very much. So, let me, this whole presentation we talked about, will be presented by me and Sonia in tandem. And let us take a scenario of a young gentleman who presents to the emergency department with fever, cough, and dyspnea. He is hypoxic, he is tachycardic, and he is tachypneic. How do you manage such patients? This is one paradigm of patients with various paradigms of patients who are requiring actually oxygen, who are hypoxic due to medical conditions, trauma conditions, surgical conditions, adult and pediatric. So definitely the mainstay of treatment here is the oxygen, which is like a drug, as Dr. Rakesh rightly pointed out. So the objective of this whole topic is to discuss what are the causes, diagnosis of hypoxemia, and how it will be prevented. How do you actually do an oxygen audit, and what is the leadership role nursing can play in doing this and making a system of oxygen audit. Hypoxemia is defined as the partial pressure oxygen of PO2 less than 80 while breathing in room air, and there are various classifications from normal to mild, moderate, and severe hypoxemia. In nutshell, if the patient presents to you with on baseline hypoxia as low saturation, or the patient is on oxygen therapy and the dipping of oxygen levels, you say the patient is having hypoxemia. The symptomatology, patient can have various paradigms of symptoms, like we know that when the patient is hypoxic, the patient can be agitated, patient can have headache to confusion to coma, and patient can present it with chest pain, and patient can have dyspnea. So how do you diagnose hypoxemia? It is based on the clinical symptomatology, and where the patient will be tachypneic, patient, and having cyanosis is a late sign of hypoxemia. So one should not wait for that, And we do a pulse oximetry. You can do also that you can do a stress test, like, you ask him to walk for 6 minutes and look for drop in oxygen saturation, which is the early telltale signs of hypoxemia. You can do a arterial blood gas. You can do, so this is a various tests you can do to diagnose hypoxemia. You can use what is the cause of this hypoxemia, whether it is due to COVID related or non-COVID related. So you can, based on the symptoms and clinical signs, you can divide into various systems which is causing hypoxemia, basically cardiac or respiratory, and use various modalities of testing to identify the cause of hypoxemia. But it is very important for us to assess and manage simultaneously, which is so key. So once we know that the patient is hypoxemia, you need to do a quick triage. You can use various ways of doing oxygen therapy, medications, and supportive care, and treat the cause that kills first. So we know that it is very important, it's very difficult and challenging to manage hypoxemia. So how we can prevent hypoxemia, especially in patients with COVID-19, that you can use various modalities like awake proning, deep breathing exercise. You can do mild exercise, hydrate yourself, and you should use healthy diet. So we know that hypoxemia, various causes are there, and one of the key aspects is oxygen therapy. So let us understand what is the current status and the audit one can do of oxygen therapy. Now hand over the stage to Sonia to take it over from me and continue.
Thank you, sir, for enlightening all of us, and good afternoon to all the respected dignitaries. So in this presentation, right now we have mentioned that the main treatment for the main drug of choice for the treatment of hypoxemia is oxygen. So a study was done by the AIIMS Emergency Department in collaboration with Niti Aayog, and the key point pertaining to this particular topic, which was highlighted, was what is the current status of equipments related to airway and breathing management in secondary and tertiary care hospitals. So 34 secondary care hospitals were included in the study, and 100 tertiary care hospitals were included in the study. And in this study, it has been found that the compliance to the availability of basic airway management devices, for example, LMA, ET tube, AMBU bag, it is not up to 100%. We can say it is very much lacking. And but however, the good part was the main source of oxygen was oxygen cylinders. So we can assess that in district level hospitals and tertiary level hospitals, if the there is so much gaps, and so there was a need for oxygen audit. How can we judiciously use this very important drug, which is oxygen? So oxygen audit mainly aims at rational use of oxygen, streamline the oxygen supply from different sources of oxygen, ensure safety measures in oxygen delivery system at facility level, regular and periodic facility-based audits by dedicated oxygen audit team. And this particular need for oxygen audit was also supported by Ministry of Health and Family Welfare, and they issued the guidelines for hospital administrators as well as healthcare providers. So for hospital administrator, the recommendation was given to form oxygen monitoring team in each and every hospital, which will include the nurse and the OT technician in each shift. The responsibility of these nurse and the technician or oxygen monitoring team is basically to inspect the gas pipeline, monitor the gas outlet as well as the cylinders to detect any leak. And also they are supposed to sensitize nurses and technicians for conservation of oxygen. Also, they are supposed to inspect all the patients who are getting oxygen therapy, whether it is really recommended. I mean, the rational use is being given by the doctor or not. Or also, if there is the mask or the devices which they are using, it is appropriate. And also, they are supposed to check the stock or supplies in the clinical areas, and feedback they are supposed to give to the oxygen audit committee of the hospitals. And oxygen audit committee will include the clinicians, hospital administrator, and the administrator, which are basically responsible for the oxygen consumption of the hospital, proper auditing of the oxygen supply in the hospital, maintenance part, and administration of the part where the procurement of oxygen is being done. So apart from that, the recommendations were for healthcare providers, and in which the strong recommendation was given that individualization of oxygen therapy depending on the need of the patient. For that, the SpO2 level, target SpO2 level has to be assessed for each and every patient. And also the respiratory status of the patient has to be assessed, and accordingly the oxygen therapy has to be instituted. And also the recommendation was for escalation of oxygen therapy should be done from CPAP to BiPAP or high flow nasal cannula based on the clinical response and in consultation with the clinical doctors. And also the healthcare providers should audit the oxygen use within their clinical area so that they can improve themselves. The main focus areas of oxygen audit are oxygen prescription, prevention of oxygen loss, periodic triage, and oxygen conservation. Oxygen, like any other drug, the oxygen has to be administered to a patient only with the prescription. So the role of nurse is very important. They will have to ensure that doctor has prescribed the oxygen and how much liter has to be given to the patient, which device has to be used, what should be the target level of SpO2, and continuous monitoring of the patient who is getting oxygen therapy has to be done. Use of right device is also very important, whether the patient is supposed to use the nasal cannula or the patient is supposed to use nasal prong or oxygen mask, non-rebreather mask. So that has to be completely clear to the nurses, and they should do it as per the prescription of the doctor. Continuously monitoring should be done for the respiratory rate, saturation, ABG of the patient who is getting oxygen therapy, and accordingly use this is a checklist which is recommended by Kerala government. So like that we should document about the oxygen therapy to the patients. So in this day, time, respiratory rate, oxygen saturation, oxygen, what oxygen device is being used, what is the flow rate, it has to be done periodically. And also it will be good if like we are doing TPR charting in the chart where graph is being plotted. So that way only SpO2 monitoring has to be plotted in the graph, and that will guide us for increasing or decreasing the or escalation or triaging down the patient for oxygen need. And also the nurses are supposed to anticipate adverse effect of the oxygen therapy, continuously monitor the patient for that, and treat if such adverse effects are there. Periodic triage, the role of nurses is very important. Triaging of the patient as per their oxygen status should be done at regular interval, because once you have started with oxygen, it is not necessary that the same flow rate or same device the patient will use for the entire period. So it has to be continuously evaluated, and if there is need of step down or step up, it has to be done by the nurses in consultation with the doctor. And it has been shown that oxygen therapy, de-escalated oxygen therapy is needed as patient improves clinically. Also, if SpO2 is more than 94% for 12 hours continuously, then patient should be switched over to intermittent oxygen therapy, and then again he can be shifted to room air. Oxygen conservation. In the last pandemic, COVID pandemic, we all have seen the surges of patients with COVID-19, which has led to shortage of oxygen in many hospitals. And this kind of labels we have also witnessed in the hospital. So what is oxygen conservation? The judicious use of oxygen therapy in individual case, and to enhance the accountability of oxygen conservation through monitoring and audit without compromising the quality of care. So this point is very important. We should give the oxygen therapy without compromising the quality of the care to the patient. So adequate, whatever patient is requiring, that oxygen has to be given to the patient, simultaneously keeping in the mind that oxygen should not be wasted. So to prevent the loss of oxygen, the nurses can play a very important role. They can inspect the oxygen source in each shift. We should check the wall mounted and also the cylinders, that there should not be any leakage, and closure of the valves in pipeline system in no use area has to be done. If wall mounted oxygen is there, sometimes we can see the valve is open, so that has to be periodically checked in each and every shift in wards as well as in emergency departments, and close it whenever required. Use of adequate fit of right size mask or non-breathing mask is very important to avoid the wastage or oxygen loss. Ensure right size of endotracheal tube with optimum cuff pressure so as to minimize the leaks. We should maintain base flow in ventilator to minimum if it can be according to the clinical condition of the patient. Standby mode can be used if for the ventilators. For example, if somebody is doing suction, so standby the ventilator should not be kept on. It can be kept on standby mode, and after suctioning immediately, ventilator can be connected. Use of closed. It has been proven that use of closed suction devices prevents the oxygen loss to some extent. as we all know that oxygen is a gas which can catch fire easily. So fire safety in our own clinical area is very important. I have mentioned about the cylinders because in India, most of the area cylinders are the main source of oxygen. So do's and don'ts of has to be followed to prevent the fire safety while using oxygen therapy. Here to take home message is recognize, resuscitate, and refer the patient in time. There should be optimal use of oxygen therapy in the optimal use of oxygen therapy is cornerstone to the treatment of hypoxemia, and oxygen therapy should be individualized to the need of the patient, not like, blanket, it should not be blanket, it should be on the basis of individual patient's condition. Nurse's role is highly important in oxygen administration, conservation, and prevention of wastage. And I must say that we should all do what we can with whatever we have and wherever we are. And I'm sure we together we can and we will make the difference, and we will fight. We will against this corona pandemic. We will, just go through it. Thank you.
Thank you, Dr. Sajeev Bhoi and Sonia Chauhan for a very, very crisp presentation. I can see in the chat box there are no questions. So in case anybody wishes to ask any question amongst the panelists or the speakers, please feel free. If not, then I have a quick question, Sonia. Could you throw some light on the role of documentation, especially regarding the oxygen administration charting? You've shown us a chart over there.
Yeah, so role of documentation is very important in whenever we are giving oxygen. First of all, as nurses, we must ensure that the oxygen has been prescribed by our doctor. Number one. Number two, when we are documenting, we must document the what oxygen flow has to be given to the patient, and what is the flow rate which we have set, what is the SpO2 level of the patient, what is the respiratory rate of the patient. And it will be good. I have mentioned in that slide also. Now also I am mentioning. It will be good if we are mentioning the clinical condition, respiratory rate, and the SpO2 in the form of a graph. Then it will guide us to further, increase or decrease the demand for oxygen for that particular patient. Also, it has to be continuously monitoring of the patient. Whatever the patient's condition is, it has to be documented properly. The nurse's role is very important, and it has to be signed properly, so that it is guiding. It is a type of communication to other team members as well, if we are documenting it properly.
Thank you, Sonia. Dr. Sanjeev Bhoi, I would just want to hear your comments on the hospital oxygen audit committee, and where do you see the role of a nurse in this?
See, thank you for the question, madam. And the oxygen audit committee, so it actually as an integral part of any, especially during the respiratory epidemic where you need to conserve oxygen, and any epidemic such as this, is getting a real-time feedback. The committee's role is to getting a real-time feedback from the floor. And the committee also should ensure that various clinical areas like emergency, critical care units, the general wards, where the patients are being managed. So you should have teams on place, like you have a nurse or a OTA who is being form a critical part of the team of each area, who are to take a leadership role, not only in monitoring and evaluation, also to do capacity building of the healthcare provider of the particular area, and also get real-time feedback to this committee. This committee, committee means only the 4 or 5 people is not committee. The whole hospital, along with these people, the workforce on the ground who are taking leadership role on various clinical areas, becomes the core chain in hub and spoke model within the hospital to form this committee. And also because their role of capacity building. Till now, oxygen has not been seen as a major drug. So here we are changing a new paradigm for our healthcare workers, that it is a drug. So that's why this has to percolate right to the ground. So this chain of command and will give real feedback and then you do rational use, getting the supplies on, getting the supplies and equipment, getting the training, continuous training like we are having today, national seminar. Similarly, the person who are listening to us should go back and form the oxygen audit committee along with this small oxygen leaders. You know, the nursing leaders can be the oxygen leaders of the ward or the ICU or the emergency. In each shift, there should be a designated person who will take round of the particular ward or ICU or in the emergency, you know, and they will report in the report book. They should write it down. What are the problems they had? What are the things? And then it should be communicated to the nursing oxygen leaders of that particular ward or this thing. And they should give, because nurses are good documenters, you know, they're excellent. So they can give that feedback to the hospital audit committee. So if the data does not come from the floor, madam, you know, nothing, the oxygen audit committee cannot do anything. It is actually spineless oxygen audit committee. So these are the persons who should collect data. For collecting data, you should go to have a nursing chart. You know, so separately one cannot fill. Like you are maintaining a TPRBP chart, you know, we have been doing, nurses are excellent in that, and they plot the time motion, you know, the graph and the temperature, like you doing temperature at different time point, what was the temperature? When you gave PCM, what was whether it went down or it did not respond, then what you did. Similarly, oxygen therapy can also be done like that, you know, so it can be a feeder. That will be the real audit of the patient, you know, and the same audit will collect the data for central oxygen committee members. So these are some of the few feedbacks I wanted to give it for those who are listening to us across the country. Thank you for the question, ma'am.
Thank you, Dr. Sanjeev and Sonia once again. And we have really understood, and we hope that we'll be, with the nurses listening to these programs, will continue to be the oxygen leaders wherever they are working, so that the auditing of oxygen is a continuing process. Thank you so much. Over to you, Kavita ma'am.
Thank you so much, Colonel Sarabjit. And I think that was such a fantastic session. Thank you so much again to both Madam Sonia as well as Dr. Sanjeev. I mean, I feel like, you know, all of us who may be, you know, all the administrative folks also probably learned a lot on how we need to do audits, and audits not just for oxygen, but audit in general. The idea of measurement is so important for managing anything. So I think you've really, I think it's excellent for the nurses to listen to, you know, from their nursing leaders itself. So thank you again. It was extremely useful. Thank you. And I just wanted to make one quick logistical announcement before I thank Dr. Sarabjit as well, which is that all the link to all the videos and the PowerPoints, as and how the sessions are happening, you will see that we are pasting the links on both the YouTube link site as well as on the WebEx. So you can go in, and if you click on the drive, we request you to please, everybody, see the chat box. You can open it and you will be able to download it on your computers. So hopefully you can see all the video demonstration videos clearly and multiple times, you know, with your volume controls, etc., and take good advantage, because they have been demonstrated, recorded live at the AIIMS set studio a month ago when we kicked this off. So I request you to please take advantage of it. Colonel Sarabjit, thank you. We could not have done this without the excellent cooperation and, you know, the leadership of the INC and of with the AIIMS College that has really sort of pulled this thing together. So I know you will be here all through, but I on behalf of the Ministry of Health and Family Welfare, have to thank you for, particularly for having, you know, brought all of these folks together and for all of your leadership. So thank you. And it is now my privilege to actually, again, because some people haven't heard Professor Deorari yet, he really is the vision for this entire capacity building piece in the last 6 months, all of the work that has been happening. So he's going to obviously be answering some Q&As in between, but I think it is important for the nurses, sir, to have your inspiring messages always now and during the course of the session. Over to you, sir.
Thank you, Kavita, and wonderful Sarabjit, Sanjeev Bhoi, and Sonia for making an excellent presentation. So, as we know and we saw in the last month, in each and every district, we have oxygen stewards who are given the responsibility of making sure that the back end and the supply of oxygen in each and every hospital is going to be maintained. And I would strongly agree with what Dr. Bhoi said, that we need to have a committee or an audit team in each and every hospital. Oxygen is not required only for COVID. It is also required for non-COVID patients. and it is an important part and parcel of any health system which provides care for sick patients. So as we know, in many of the hospitals, we have hospital infection control committees. They work 7 days a week or 6 days a week, and maybe 1 day or 2 days, that same committee can be given a role for taking care of, as a nurse leader, to take care of whether the audit process for oxygen is happening in various hospitals or not. Because it is very hard to create new positions of separate nurses who will be allocated for oxygen audit in the hospital. It is the responsibility of each and every nurse and a doctor who is writing orders for prescription for patients, that how patient has to be given oxygen, what devices to be used, how it has to be de-escalated, what monitoring has to be done. It has to be a part and parcel of each and every prescription for the patients. There are few questions which are very common questions which someone is asking, that the patient is coming to the hospital in the triage room. We are not able to record the pulse, and patient is dehydrated, in shock. What should be done? I think our primary responsibility is, Dr. Bowie would agree, to first manage the condition which is going to kill the patient, maintain the airway circulation on the patient, and then look forward whether you are able to get any oxygen saturation with the help of pulse oximeter. There is one more question which is there, that the pulse oximeters which we use, will all the brands of pulse oximeter give the same reading? It may not be true. There may be a variation of 1 to 2%. But if you are recording the saturation with one pulse oximeter, that will give you the baseline, and that will tell you whether you are hyperoxygenating the patient or your patient is becoming hypoxic. So use the same pulse oximeter for the patient. And there is one more question, that in the time of pandemic, how do you ensure that your oxygen supply is going to, I think Dr. Bowie and Sonia covered that. We always have backup in place. In addition to PSA, liquid oxygen, many of the hospitals will have oxygen cylinders which will be there as backup, or oxygen concentrators which are there as backup. Luckily, in third wave, we are so lucky that Omicron is not affecting the lung as it Delta affected. So the need of oxygen in all the healthcare facilities is not so high at this point of time. And the critically sick patient with pulmonary complications are not getting admitted. And my last question is to Kapil. Kapil, the question is for you, that for a patient who has got chronic obstructive pulmonary disease, what saturation levels should be maintained in that patient while we are doing triaging and managing the patient in the hospital?
So as previously specified, and I will cover that in my talk as well, we don't need to maintain 100% saturation in any patient. The target saturation in a COPD patient is somewhere between 90 to 92%, and that is good enough. I'll discuss about what is hypoxia and what is the disadvantages of hyperoxia as well. So let me deliver talk.
Because there was a question on this, and there are 3-4 questions on newborn and children. So I would leave that to Sushil Kabra and Anu Sachadeva to cover their presentation, and I'm very sure the questions will be answered there. So over to Kavita and Lata.
Thank you, sir. And before I turn it over, I know Dr. Lata is pretty much just there and chairing on behalf of sort of this entire session. And thank you, ma'am. I am because we have quite a few presentations still, and I'm also cognizant of time. So I will quickly turn this over, and it is my privilege to invite Dr. Roy George from the TNAI, from the Trained Nurses Association of India. Thank you, Dr. George, for being here, and for you've been a very, very ardent supporter of our program for the last several months. We know, as all of these capacity building modules have been put together, and you all do such a massive job in terms of training yourselves. We would love to please invite you to chair this particular session, which where Dr. Kapil Soni will be now speaking, but request you to please come on. Over to you, Dr. Roy.
Very warm good afternoon. Thank you, Kavita, for this event, and respected the organizing team led by Dr. Lata and Kavita Narayan, honorable chairpersons, and most renowned resource persons of the day for this wonderful webinar. First of all, let me congratulate and thank the organizing team for organizing a series of capacity building programs on this during this pandemic. And oxygen therapy and rational oxygen therapy is one of the very important aspects of this ongoing pandemic. And let me start with paying tributes to the health workers in India who have lost their life, especially the nurses. As per the data available with the TNA, we have lost more than 130 nurses who are directly on the line of care of COVID duty. There are many other nurses who died during the COVID pandemic, but these 130 nurses were on the direct line of duty. I pay my tributes to them, and let us continue the struggle against the COVID by getting updated periodically on this ongoing pandemic. Since we are running short of time, let me directly, and we had seen the indications for oxygen therapy we have heard about and we learned about from the expert oxygen monitoring and also about oxygen audit and documentation. Now let us go per se into the oxygen therapy. And to talk on adult oxygen therapy, we have a renowned expert, Dr. Kapil Dev Soni, additional professor of Department of Critical Care, who have the critical care departments in all the major hospitals have been busy managing critically ill patients due to COVID-19. And we are sure that we will be learning a lot from him. And with the best wishes for a fruitful session, over to you, Dr. Kapil Dev Soni.
Thank you, sir. Thank you. It's my privilege to speak in front of all the nurses and all the august listeners. First of all, I must thank Professor Devrari and Minister of Health and Family Welfare for giving me an opportunity to work for oxygen stewardship. And we have been working from last 4 to 5 months. I must thank Ms. Kavita and her team that has done a superb job to design a module which can be disseminated, and it can be really useful if it can be propagated or promulgated in various parts of the country. So just for beginning, I must echo what Professor Boy said. Oxygen is a drug. It has to be audited. It has to be conserved. And what Dr. Boy said is such an important thing that you should have leaders who are working with the patient round the clock. And they are none other than these are the nurses who can take a central leadership. They are always at the bedside of the patients. They can manage the oxygen better than anybody else in the clinical setups. So they are the specific point person who can determine whether we are doing right job for the patients or we are actually wasting the oxygen. So having said that, what I will do is that I'll just run through most of the things you have already listened from the previous speakers. In case you find any difficulty in understanding concepts, do let me know, and I'll be happy to answer the questions. So what is an oxygen? Oxygen is basically a drug. It means if it's a drug, it has got both the advantages and it has got the side effects. What are the advantages? Specifically, it has to be used in acute hypoxemia. We know hypoxia is a bad. However, we have often overlooked hyperoxia is also a bad thing. So what this current pandemic has shown that we don't need to give or keep 100% saturation in all the patients. We can actually titrate. And if we titrate the oxygen based on the clinical condition of patient, the outcomes are much better. The length of stay is lesser, length of stay on ventilator is lesser, length of stay in hospital is lesser. So oxygen has to be conserved and used as a drug. You have already heard about what are maybe the etiology of acute hypoxemia. I'll not go into detail, but just to run through, specifically in COVID-19, it was pneumonia which was causing a principal lung involvement and hypoxemia. Other thing what we found in patients who are coming with COVID infections were having dyspnea or a shortness of breath. And most commonly, these patients have two important features: who were admitted in intensive care unit or who were requiring a moderate to severe critical care. They were developing hypoxemia, and they were unaware that they were having hypoxia, but their work of breathing was more. They were developing shortness of breath, which was more common. And these two were the most common symptoms which we encountered in the previous wave. This time, luckily, we are not finding patients who are coming with hypoxia anymore. And this time, this is more of a milder wave. But last wave, Delta wave, it was really difficult period. So what oxygen target we should set in? As I said, we don't need, no patient actually required 100% oxygen target. Now, this we knew from last almost a decade, but this COVID-19 pandemic brought that in a limelight. We just need to keep target somewhere between 92 to 96%. And if the patient is a COPD patient, you just need to keep target between 88 to 92%. That's the saturation target you should achieve, or you should go for if the patient is having admitted in your hospital or in your care wards. In severe cases, when if a patient is non-pregnant, we should target around more than 90% is good enough. And if it's a pregnant patient, we should keep between 92 to 96%. So overall, the sweet spot is somewhere between 92 to 94%. That's all you need to keep in. If you are able to achieve that target most of the time, the outcome of your patient would be better. It's not about just only to conserve oxygen, but it's also important to remember that if you use it as a very precise control of oxygen, then your patient is much better. He wins off from the ventilator very quickly. He can leave the ICU in a way sooner, and he can actually have a shorter hospital stay. And that's actually beneficial for whole of the patient population. That we must understand. What are oxygen delivery devices? You have already heard from previous speakers, specifically the Professor Rakesh Garg has talked about it. There are multiple devices which are available for our armamentarium. There are nasal prongs, face mask, partial rebreathing mask or a rebreathing mask. And then there are the host of new devices such as high flow nasal cannula, non-invasive ventilation or CPAP device, or finally the invasive ventilation. I'll not go too much in details, but remember these are all available. What to use would depend upon what the patient demands. Oxygen therapy has to be individualized. Not all patients would require a very high flow nasal cannula. Most patients can be managed with simple nasal cannula, or they can be managed with non-rebreathing face mask. So as a front warriors, you need to remember not all patients would require a higher oxygen flow therapy devices. Most patients can be managed with lesser or devices which are much simpler in nature. So what is nasal cannula? I'm sure most of you must be aware. It's very pliable. It provides a lot of comfort to the patient. And if you can titrate up to 40%, you can increase flow up to 6 liters per minute. But beyond that, if the patient workup breathing is more, then the delivered oxygen or FiO2 decreases and it becomes inaccurate. So if the workup breathing is less and the patient is mildly hypoxic, you can start with a nasal cannula. And if you find that patient is progressing towards hypoxemia or is not responding to it, or the workup breathing is more, or the respiratory rate is more than 22, then switch over to other device. Simple face mask is again an oxygen device, which can be a conventional oxygen device. It actually adds 200 ml of capacity of a reservoir. You can give a flow rate of up to 6 to 10 liters per minute. And with increasing respiratory rate or increasing ventilatory demand, the delivered FiO2 decreases. So it's useful as an initial mild hypoxemia, but if the patient is in a moderate to severe disease, then this device may not work. Now, what we found in our own practice is the use of rebreathing face mask. There are two rebreathing face masks. One is a partial rebreathing face mask, and then there is a complete or a non-rebreathing face mask. In a partial, they are almost similar, but there are some minute differences. One, in a partial rebreathing face mask, it actually allows rebreathing of some sort of air, and delivered FiO2 can achieve up to 80%. You can deliver flow rate up to 6 to 10 liters. And if the bags can collapse, then it increases the work of breathing. However, what we use as our workhorse was a non-rebreathing face mask. Now, during the second pandemic, when we realized that not all patients we will be able to provide ventilatory support, or not all patients we would be able to give them a high flow nasal cannula, we started those patients managing mainly on non-rebreathing face mask. Non-rebreathing face mask became a working horse for us, and it was used in almost all patients who were developing critical hypoxia or who were presenting to the hospital with hypoxemia. So what it is, it can deliver 100% of oxygen. Practically, it can deliver up to 80% of FiO2, and you can increase flow rate up to 6 to 15 liters per minute. And again, remember, this takes care only the hypoxia. With the settling of hypoxia, most patients would have a decrease in respiratory rate, and that would also decrease the work of breathing. But in case the work of breathing is doesn't decreases, then you need to escalate your therapy. Venturi mask was also available, but we all know that you can deliver a specific FiO2 with the Venturi mask. However, it was not that used in our own practice, but it's one of the available options which you can use. High flow nasal cannula has come up a big way. This device was, prior to COVID-19, it was sparingly used. It was used more in a trial settings. It was used more in a ICU settings in a few places. But what we found with the using of a high flow nasal cannula, that it reduced the need for intubation. And compared to other non-invasive ventilation, it actually reduced the hospital stay, reduced the ventilatory stay, and also, though there was no effect on the overall mortality, but it does help in prevention of intubation, which is one of the prognostic marker. So it can deliver very high oxygen, up to 100% of FiO2 can be delivered, and you can achieve very high flow rates. Now that's a very high, 40 to 60 liters per minute. It means if the minute ventilation or the ventilatory requirement of patient is quite high, you can supplement that ventilatory requirement by using high flow nasal cannula. It does have some sort of CPAP effect as well, and it also prevents that air hunger. It's sort of very comfortable device compared to the CPAP device, which is normally delivered by using a face mask or by a helmet. So compared to that, high flow nasal cannula is much more comfortable. There are ways to increase or decrease the flow rate. There are protocols to increase or decrease the FiO2. So that needs to be titrated. Now, if you are using high flow nasal cannula, it's not only important to increase the flow rate and delivered FiO2, but to de-escalate also very quickly once the patient improves or once the patient doesn't need further oxygen. Unless you do that, you would end up in wasting a lot of oxygen, because this gives you 60 liters per minute, which is very high oxygen flow, which has been delivered to the patients. Another option is non-invasive ventilation. We are all familiar. It can be delivered through a mask. It can be delivered through a helmet. So there are multiple interfaces which can be used. It is specifically useful in patients whom the respiratory rate doesn't settle down with high flow nasal cannula or with other conventional oxygen therapy, and there is increased work of breathing. You can see the patient is using accessory muscles to breathe. Their respiratory rate is very high, 24 to 30 breaths per minute. In that scenarios, non-invasive ventilation should be attempted. What does it do? It reduces the work of breathing and it improves the oxygenation. Now, what are the side effects? What are the contraindications? The problem is that if the patient is unable to protect airway, or patient is unconscious, or patient is having vomiting or excess secretions, in those conditions, it may be detrimental. So it's not that just putting a non-invasive ventilation, you forget about the patient. You need to know whether the patient is actually tolerating it or not. Sometimes if it's not tolerating or not improving, or the disease is worsening, then you need to switch over to the intubation as soon as possible. Advantages, as I said, there's a minimal leak compared to the helmet, compared to the mask. If you are using helmet, then there are certain advantages that it effectively lowers the work of breathing. There's a lower chances of leakage. There's a minimal risk, right? What do you do? So WHO guideline clearly state that NIV should be used, and if you have escalated your oxygen therapy and you have used conventional oxygen therapy which is not working, patient should be switched over to NIV ventilation. But once you are putting on an NIV ventilation, we must ensure that there would be a lot of aerosolization of COVID-19. And in previous way, we found that the Delta was quite infectious. It could cause healthcare COVID infections. So that has to be taken care of when you are using non-invasive ventilation. As I said, there are various ways you can use non-invasive ventilation. There are interfaces, oronasal, nasal pillows, total face, mouth. There are multiple, but commonly what we use is in our own practice is the face mask. Does NIV help or harm COVID-19 patients? Now, as I said, just like HFNC or high flow nasal cannula has shown that the patient risk of intubation decreases. Similarly, the NIV has also shown that if you use in a specific subset and if the patient responds, then the chances of intubation does decrease. And that can be, so if you're going up the ladder of oxygen support, then if the HFNC doesn't work, try go down to NIV, and if you feel that NIV is not working, switch over to intubation as soon as possible. Remember that if the patient has developed moderate to severe ARDS, then the failure rate is almost 50%. So there are multiple evidence which clearly shows that CPAP or a high flow nasal cannula is better compared to the conventional oxygen therapy in reducing the need for intubation, as well as decreasing the hospital stay. However, the mortality was not affected. How to use it? We all know that there are standard protocols. You have what a full face mask, use a double circuit, CPAP, start with the IPAP, EPAP of somewhere between 5 to 6 and 10 to 15 centimeter of water pressures. Reevaluate. It's not that just put patient on a one oxygen device and forget. Always have a habit of reevaluating after say half an hour to 1 hour. See how your patient is responding. What is the trajectory of your patient response? And if you clinically determine that the patient is not improving or worsening further, don't delay the escalation. You need to monitor all the vitals, you need to monitor respiratory mechanics, you need to monitor the patient's condition, and all that needs to be done when the patient is on mechanical ventilation. Contraindication, as I said, if the patient is unconscious, if he has an inability to protect airway, or there are other conditions which preclude use of NIV, then it should not be used. Now, intubation and mechanical ventilation. Now, with the beginning of pandemic, there was a lot of talk that if you intubate, most patients would die. However, we learned throughout our pandemic that it's not so. We evolved our own assessment when to intubate and when not to intubate. So when to intubate is you start with oxygen escalation therapy. You have consumed other oxygen devices that include the non-breathing mask, the high flow nasal cannula, even the use of NIV, and now the patient is further worsening. In that case, do not delay intubation. Go switch, put the patient intubate, put the patient on mechanical ventilation. And in our own practice, what we found that putting someone on a mechanical ventilation was not the end. Almost 50% of patients came out from mechanical ventilation. So that was really heartening, but it has to be done at very appropriate time, not too early and not too late. What are the classical indications if you from NIV to invasive ventilation? One is that if the patient is clinically worsening, he is becoming drowsy, there's increased work of breathing, there's increased oxygen requirement, the underlying condition is deteriorating, or the patient is developing new complications, hemodynamic instability, vomiting, or have a progressive disease. In all this, or patients have not tolerating non-invasive ventilation. These are all indicators that now it's a time to switch over to invasive ventilation. Once you switch over to invasive ventilation, now what you need to do, remember, you were treating the patients who are having severe ARDS or moderate to severe ARDS. Now, there are only three things which have shown improvement in a moderate to severe ARDS. One is low tidal volume ventilation or a lung protective ventilation. That means you need to keep tidal volume somewhere between 4 to 8 cc per kilogram of predicted body weight. Secondly, use of prone positioning, that you need to prone your patients at least 12 to 16 hours per day. And third thing is use of neuromuscular blockers. So there were only three things which have shown some benefit in the patients who have developed severe ARDS and helped in reducing the mortality. So how do you decide? Again, I told you need to follow the patient trajectory, and there's none other than who can do it is your nurse. She or he knows how your patient is actually behaving. Is he improving? Is he deteriorating? He or she would be the first person to raise a red flag that doctor, this patient is deteriorating. He's not tolerating what you have given. So listen to your nurses. They are your best informers. They would tell you that patient is not responding to therapy. Now switch over to or escalate the therapy as soon as possible. Do's and don'ts, they are very classical now. Everybody should know that what are do's and what are don'ts. ARDS, as I told you, a severe COVID or a critical COVID is basically a moderate to severe ARDS. In severe ARDS, we need to prevent ventilator-induced lung injury. So that can be prevented by alveolar overdistension, hyperoxia. Don't give too much of oxygen. Just target somewhat below around 90% of saturation and avoid cyclic alveolar collapse. Prone positioning is again indicated. These are the lung protective mechanical ventilation. This is a classical and pretty standard now. Reduce the PEEP, reduce tidal volume, allow high plateau pressures in patients who are obese, or with a reduced chest wall, prone your patients, and manage the airway pressures, which can actually further damage the lungs. Set tidal volume around 6 cc per kilogram. Choose SPT rate between 10 to 35. Determine how much oxygen is required. Target the driving pressures or the difference between the plateau pressures and the plateau pressures and the PEEP. Clinically observe the rise of the chest. Do multiple gases, which can help you in tailoring or what we say tailoring the therapy based on the patient's response. Putting someone on a mechanical ventilation is not an easy job. Actually, it can lead to a lot of complications. What we found in our own patient groups, one of the common complications was the barotrauma or a pneumothorax or a ventilator-induced lung injury. So these were quite common, specifically in the COVID-19 patients. That was because the opacities were predominantly situated on the periphery, which were leading to increased incidence of pneumothoraxes. So that needs to be cared about. Prone positioning, in case your patient is not responding to the therapy or patient is falling in moderate to severe category of ARDS, do not wait. Prone your patients. It has been shown that if you prone your patient, the mortality does decrease in severe ARDS patients. And Dr. Boy and Dr. Rakesh Garg also talked about the role of awake proning. Awake proning should be advocated in all patients who are able to lie. If not, then they should be they should be advised to lay at least lateral if they are not able to prone the patients. But if the patient is intubated on mechanical ventilation, just prone your patients at all times. Conclusion, remember, oxygen is a drug. It can prevent hypoxia. On the other hand, it can cause hyperoxia. And hypoxia and hyperoxia both are bad. Use oxygen quite judiciously, not only in escalation, but also de-escalation. Devices should be based or selected based on the need of the patient. So that needs to be individualized. Each device has its own limitations. Each device can cause complications. Mechanical ventilation, though it looks quite fancy, but remember, it's a double-edged sword. Patient can be saved, patient can be killed on mechanical ventilation. So remember, you need to be very sure of whom to keep, how to monitor the patients who are put on mechanical ventilation, and what all you can do. Intubating, when to intubate, this is a common question which everybody asks. There is no early or a delayed intubation. Patient has to be intubated when he requires. That means someone needs to follow the trajectory of disease. Someone needs to follow the trajectory of the patient. Is it improving? Is it deteriorating? What is how the patient is behaving? So that has to be individualized. Thank you. Thank you for patient listening.
Thank you very much for that wonderful session, Dr. Kapildev Soni. And there's one question already come in the chat box. How long we can use NIV mask? I think the period is how many days or something. That is, I think that is.
So as I told you, there are certain scores which you can use. One is ROX index, and there is one other HACR index is also there. These are all scores. However, practically when you are dealing with these patients, if you apply a non-invasive ventilation and within 4 hours you don't see any improvement, or you find that patient is not responding, not tolerating, or the disease is worsening, then you should not keep on going it. You should think about putting intubation and mechanical ventilation, invasive ventilation, rather than continuing NIV. It has been shown that if you continue to give NIV, it causes delay in intubation and worse outcomes. So within 4 hours, you would be able to assess whether the patient is responding, whether the disease is stabilizing, and whether there is some improvement in the underlying gases.
Any more questions? I think you have covered it so well, from the therapy indications to the complications. I think the normal questions popping in the chat box. Anything from the panels?
Yeah, so I think there are 2 questions for him, Kapil.
Yes, sir.
First question is, what are the infections which are related to oxygen administration?
So there are no specific infections which are related to oxygen administration. What we have, patient may develop hospital-acquired pneumonias or ventilator-associated pneumonias. Now, the cause of these infections can vary based on where the patient is being treated. Most commonly in our country, we have predominance of gram-negative infections. Patient would often develop ventilator-associated pneumonia with gram-negative organisms. So that's one of the downside of using putting patients on mechanical ventilation.
Second question is, can we use normal water, tap water, instead of distilled water in humidifiers?
So again, humidifier is considered as one of the source of infection if it is get infected. It's advocated to use distilled water, but if we are sure about sterility of a normal water, that can also be used. But distilled water is preferred and more safer for the patient. You are unsure about what is the how much sterile is the normal water.
Yeah. So last question is for you, Kapil. Any device to measure oxygen leakage from wall-mounted oxygen supply pipelines?
Well, I think I'm not aware of a specific device which is to measure how much leakage is there. In a mechanical ventilator, you can easily do that because you can read on the sensors how much is delivered and how much is not expired and how much is getting leakage. That's easy to do on a mechanical ventilator. But from wall mount, there is no specific device. One has to check consistently or periodically is there any leak from the wall mount or not.
Yeah. So there is one more question, which is what will happen if a patient of COVID patient inhales excess of oxygen due to malfunction of equipment? I'm sure it will lead to pneumothorax.
So definitely, if you have very high flows or high pressures, oxygen giving to the lung, no matter if it's air or oxygen, it will cause lung injury, and that may complicate to a pneumothorax. One thing is that short amount of oxygen, high FiO2 is not that detrimental, but if you keep on giving very high FiO2, we all know that it causes a lot of generation of free oxygen radicals and then the worsening of underlying lung condition. That's the downside. So oxygen, both hypoxia and hyperoxia are bad for the patient.
Thank you. So over to George, please.
Yeah, thank you very much, sir, and thank you, Dr. Soni, for that very informative session. I think you have given insights into the total spectrum of oxygen therapy with the specifics to the adults. Thank you very much, and over to you, Kumbha.
Thank you for patience.
Thank you so much. Thank you, Dr. George, for again chairing this session and again for your leadership and helping us disseminate this so widely. And Dr. Kapil, as always, thank you for your absolute words of wisdom that I know you have shared for the last several months, including helping us with all of the modules and now with sharing your wisdom to the nurses. I think they'll greatly appreciate this. I am now going to go on to a couple of logistics announcements. We are running about 15 minutes or so behind time. So therefore, I will request the next set of presenters to please keep this as short as you can, because we are sharing. So you don't have to go through slide by slide, because all the slides will be covered, are being shared with all of the participants. So if you want to just keep that quickly, because we are already at about 4:38. We said 5. We may be about 15 minutes over. Just a message to the participants as well. I think we have there's a small medical emergency / some issue because of which Dr. Sushil Kabra may not be able to join us. However, Dr. Anu Sachdeva will be making the presentation. May I please invite Mrs. Shashi Bala from the Clinical Nursing Research Society, President of the Clinical Nursing Research Society, to please chair this session. Madam Bala, over to you, please.
Yes, ma'am. Thank you, Kavita. I'm really honored to be a part of this much needed workshop. Thank you. And thanks to the organizing team, especially the Ministry of Health, Indian Nursing Council, and AIIMS fraternity, and especially Dr. Lata, who have been working tirelessly to make this a grand success. Nurses are the key health members responsible for the diligent administration of oxygen, which needs to be more meticulous in neonates and children. As we know, oxygen is a drug. Too much or too less can have irreversible damage. For this, I would like to invite here our eminent expert, Dr. Anu Sachdeva, Assistant Professor in Department of Neonatology, AIIMS, to enlighten us on the oxygen therapy for neonates and children. Over to you, Dr. Anu.
Thank you, ma'am, and heartfelt thank you and gratitude to all the organizing team and Dr. Kavita, my team lead, Professor Durari, and for giving me this opportunity. And I will be short and brief, and I'll be discussing about rational use of medical oxygen in neonates. So am I audible, and are my slides visible?
Perfect. Yes. Looking
Thank
good.
you so much. So we have defined learning objectives for this session. I would not go into that, and I would go directly hit to where we are supposed to talk about in neonates. So why oxygen in neonates? So we have already heard about this. It is the most common and abundant drug. So what do we need to do as nurses working in the neonatal intensive care unit, working in the special newborn care units? Our goal is to avoid hypoxia, and our goal is also to avoid hyperoxia. Now, why are we so worried about hypoxia and hyperoxia? So we are worried about these because when a newborn has acute drop in blood oxygen saturations, the baby would present with lethargy, poor activity, unconsciousness, can have low heart rates, can present with shock, can present with decreased urine output. If this recurs at frequent intervals, there is increased risk of death. There is increased risk of feeding intolerance or necrotizing enterocolitis. For the nurses who work in the newborn unit, they would understand this term. They could have brain injury, and these babies could also have pulmonary hypertension. So that means hypoxia is to be avoided at any cost. So why hyperoxia? Hyperoxia is to be avoided because we did hear this word retinopathy of prematurity from Dr. Lodha when he was talking about rational oxygen therapy for children. So this is something which is a major problem and the cause of blindness, because these neonates who are born before term receive higher oxygen therapy, leading to retinopathy of prematurity in the eyes. These babies can have prolonged oxygen dependency, which is known as bronchopulmonary dysplasia. Not even this, the babies can also go on to develop brain injury after asphyxia if they are subjected to higher oxygen concentration. So that means at least the last two slides tell me that yes, my oxygen has to be clearly titrated. And how do I titrate it? I would need to target, as you can see on the slide, a saturation which is above 91%. And even if I do not have a pulse oximeter available in my unit, these are the 5 clear-cut indications where I need to give oxygen. The slides would be shared. I would not go into these details, but what I need to take home from this particular slide is that always keep into mind the clinical situation. Sometimes it may so happen that the baby has an underlying cyanotic heart disease. So you give oxygen or you don't give oxygen, but baby is not going to be benefited. So remember that the single most important indication of oxygen use in neonates is hypoxemia, and we need to work together, our doctor nurses team, for maximizing the short and the long-term growth outcomes of these neonates. So the crux is maintenance of normoxia. So the question which came in the chat box, and the answer is the first box you see on my left. Nasal cannula is the preferred mode for giving oxygen. Why? You save oxygen, you can titrate oxygen better. So what is the flow that you use? Flow that you use is about 0.5 to 1 liter per minute. Routine humidification is not required. Continuous pulse oximetry is the standard. And the fifth box tells me that the saturation have to be between 91 and 95%, right? So the green box lower down helps me to titrate when I don't have a pulse oximeter. So if I see the first column below, I see that how much liter per minute I give. And as per the baby's weight, what is the approximate fractional inspired oxygen concentration that I give? This also gives me a clear area on how do I come down when I have to decrease oxygen therapy for these neonates. So what do I do? My baby lands up with hypoxia, or my baby has one of those 5 indications which I listed. So I start with nasal cannula oxygen. If the saturation, you can see on the left-hand side, continues to be less than 91%, I keep on increasing the flow. Once I reach 2 liters per minute, I switch to oxygen by hood, because giving more than that through nasal cannula may not be an optimal way. So if there is no improvement, and plus if the baby is preterm, I would actually prepone the use of non-invasive ventilation, especially CPAP, which is continuous positive airway pressure. If on the other hand, I'm maintaining good saturations, I monitor the babies beyond 95%, immediately start weaning off oxygen. And here comes in titrate oxygen. The target is again 91 to 95%. Any clinical deterioration, switch over to increase the oxygen concentration and switch over to non-invasive ventilation or to ventilation. And you may have to consider referring this baby to a higher unit. So The first carry home is empirical oxygen. I am not going to give it. I need to give it only if saturation is less than 91% and I maintain it between 91 and 95%. How do I give it? Nasal cannula is the preferred mode. I go to oxygen by hood if the requirement increases. As nursing professionals, as doctors on floor, what do you need? You need to have adequate skills using a pulse oximeter, how to use a nasal cannula, how to use oxygen hood. How do you regulate this oxygen? How do you titrate this oxygen? Remember, unnecessary and unmonitored use of oxygen can damage the entire organ. You name it and you have a damage right there. So as a nursing professional, I'm going to optimize oxygen use. I'm going to stop it when it is not required. Right? That is all from my side. Over to you, ma'am.
Yes, I don't see any questions there in the chat box. So means to all the participants or from the panelists, anyone has any questions, please?
Anu,
yes,
there
sir.
is a question in the chat box. If a newborn baby has a nose block,
right,
then
sir,
how oxygen should be given? Clean the nose?
Yes, we put normal saline nasal drops. Routine suction is generally not required. So you put normal saline nasal drops. The baby will automatically clear the secretions. Do not put the suction catheter again and again only for nasal block. Normal saline works wonders. So put luxurious amount of normal saline. The baby will either sneeze it out or swallow it with the milk. So you need not just clear the nose. I don't think that oxygen should be given only for nasal block.
So there is another one question. If you are using oxygen at low flow rate, is there need for doing humidification for that?
Routine humidification at 0.5 to 1 liter per minute is not required. However, when you're using non-invasive ventilation, you cannot use indigenous CPAP. Sometimes we see 500 ml bottles being used. For that, you require the humidification to happen because baby cannot manage with such high flow rates. So whenever using non-invasive ventilation, yes, humidification is required.
Yeah, so higher flow rate, because if you are giving higher flow rate, that oxygen is going to take humidified, it will get humidified from patient's own system and the airway is going to get dried. So in high flow rates, always use humidification system. So there is another question, madam, that, how much saturation level is considered as normal and what is retrolental fibroplasia?
Okay, so retrolental fibroplasia is something which is a pathological term. So I named as retinopathy of prematurity. For all practical purposes, ROP is in news, left, right, and center. We actually hear so much about court cases being done on doctors and units for inappropriate management and of babies and subsequently leading to blindness and stage 5 ROP. So retinopathy of prematurity would be a better clinical term for this, and we have latest definitions for this. And second thing is, I did say 91 to 95%, not 0.5 higher, not 0.5 lower. These are the latest saturation targets which are recommended as per international and national guidelines. So 91 to 95%.
Thank you. Over to Lata for next presentation. Thank you.
Yeah, actually, there is a video which needs to be shared, part of Dr. Anu's presentation. Due to time shortage, we are sharing the link in YouTube. The participants can view it through the link. Thank you, Anu ma'am, for that very detailed session on oxygen therapy in neonates.
Thank you so much, ma'am. Thank you, sir.
Madam Sashibala, you're wrapping up comments.
I think her topic has been covered very precisely and she has covered all the questions, whatever was there from our panelists also. So I think we can move ahead with the next session.
Thank you. Thank you, Madam Bala. Thank you also to Dr. Anu, who has again been a stalwart and a stoic supporter of this for so long in helping us get to this stage with all of our trainings and capacity building. Thank you, ma'am. We will, again, in the interest of time, I will please move on to the next session very quickly and requesting Dr. Jyoti Clara Michael who's from the Association of Nurse Executives of India, the Vice President there, ma'am, to please come and chair this next session, requesting both Ms. Aditi Prashant as well as Ms. Ambili to please again keep your comments as briefly as you can, because we are sharing the PowerPoints with everyone. Again, only because we are, we are probably going to be rather 15-20 minutes in any case more. So thank you for being brief in advance, and over to you, Madam Dr. Jyoti.
Thank you, Kavita. Congratulating Ministry of Health, Indian Nursing Council and AIIMS, and thanking Dr. Lata Venkatesan for hosting such a resourceful program for healthcare professionals who can make an impact. And with this, may I step into my role for the day. The second wave of COVID in India resulted in sharp increase of COVID-19 cases, leading to an unexpected outcomes. The healthcare system was compelled to handle the dilemma of an alarming oxygen shortage because of the surge in the critical cases. However, oxygen therapy can be a life-saving, but nurses must know how it works, when to use it, how to correctly assess and evaluate patients' treatment. Medication administration is one of the important accountabilities of nurses, and oxygen administration is one category that nurses should understand that it is a medication that they are administering. This calls for more involvement and empowerment for nurses. The
view on, can you just move the slide? On rational use of oxygen nursing responsibility. We know that oxygen is a complex product. So because of its complexity, access to the oxygen meets many challenges in their availability, quality, affordability, management, supply, as well as human resources capacity and safety. So when we talk about rational use, that means in terms of procurement, maintenance of oxygen supply system, coupled with avoiding misuse as well as wastage of oxygen. There are many evidences which says that liberal oxygen therapy increases the mortality without improving other patient important outcome. So we need to tackle very carefully. Oxygen misuse. Does it happen? If happens, how? Physician order incorrectly transcribed, incorrect flow meter setting, oxygen delivery apparatus improperly worn, or wrong fractional inspired oxygen concentration could be the reasons. So keeping in mind those reasons, Ministry of Health and Family Welfare, AIIMS, as well as ICMR has given certain guidelines for rational use of oxygen for the COVID-19, which says the targeted saturation should be 92 to 96%. Oxygen consumption should be regularly monitored at each hospital level. There should be oxygen monitoring committee in which nursing superintendent should be the part of the committee. Maintenance of the appropriate record should be there in terms of handling and use of compressed gases. And this committee should be mandated to supervise the inventory planning, oxygen consumption, regular repair, as well as maintenance of its pipelines. We also need to have a team of one nurse and OT technician in the team to check the oxygen mask on regular basis. High flow nasal cannula devices should be used only in the ICU setting, and that also under the supervision of various experts like anesthesiologist and intensivist. Other methods to improve oxygenation like frequent change can be noticed. Patients who are on oxygen therapy should be reviewed during their daily rounds to evaluate their oxygen requirements. Regular training of OT technician nurses to be undertaken for proper administration. At the administrative level, what we can do already has been spoken by various speakers since morning about oxygen audit committee. So we need to facilitate that. Storage facility has to be upgraded to store next 2 days anticipatory requirement. We have to track incoming supply of oxygen, and daily audit of oxygen usage in the ICU and wards can be done so that available oxygen can be diverted to the emergency care as well as in ICU departments. Oxygen prescription should be written like any other drug. That is also being discussed by Dr. Lodha, how prescriptions need to be made. Patients who need oxygen should be provided with nasal sponge. As far as possible, better to use it. If face mask is used, then avoid mask with reservoir bags. Do not use oxygen for nebulization. While using venturi mask, ensure the correct flow of oxygen. Monitor saturation continuously in the ICU to make necessary changes so as to achieve the goals. Ward in charge nurses should make regular visit to the bedside to ensure that oxygen is not being wasted. We can also do escalation and de-escalation strategies can be approved for, like de-escalate oxygen as the patient improves clinically and make use of nasal prones to administer 2 to 3 liters per minute. Whenever using any oxygen delivery device, please ensure that setting to maintain the saturation which has to be desired. Routine use of NIV in post-operative patients which can be suspended. Among ventilator patients, use minimum ventilator settings so that saturation levels can be achieved at required levels. In OTs also, we need to take care of it, like ensure that anesthesia machine is switched off once all the work of the patient is completed. Since all OTs are equipped with advanced anesthesia machine, try to use slow flow anesthesia. Ensure all gas flows are off leaving the OT. Regarding equipment, select most appropriate oxygen delivery device based on what rate we need to have it. Restrict the use of high flow nasal cannulas. Use CPAP or BiPAP when there is a lower oxygen instead of high flow is required. Ensure adequate fitting of the right size of the mask, as well as ensure right size of the ET tube with the optimal cuff pressure so that air leakage can be minimized. Use closed suction, thus preventing de-recruitment during open suction. Then biomedical team also has to take a role, like wastage of oxygen through leak should be assessed daily and rectified easily. Ensure closure of valves and pipeline system in no use areas. Stand by bulk cylinders in critical areas so that in emergencies it can be used. We need to provide training to the staff nurses, nursing assistant, ICU and OT technicians regarding the optimal use of oxygen so that any leakage or anything oxygen prescription has to be directed by the physician. Ventilator strategies to reduce oxygen consumption. Invasive ventilation saves the oxygen that we need to keep in mind. So prevent ventilator-induced lung injury. Ensure good mask which always fits and use appropriate sedation to avoid hyperventilation in patients. There are certain common conservation strategies which can be adopted, like use liquid oxygen. Oxygen delivery can be hampered by shortage of sterile water, so we can use instead distilled water. Be sure to turn off flow to manual resuscitators which are not in use. Y connector can be used to deliver oxygen from a concentrator to patients at a time who are on the same flow of the oxygen. Use an oxygen face mask or a surgical mask over high flow. This is evidence-based, which can act as a reservoir. If there are enough portable concentrator, two can be used for the same patient. And whenever possible, try to use evidence-based conservative saturation targets. Oxygen cutoff drill can be done in the hospital so that mock drills can be conducted in all the hospital on a regular basis to meet the demand. So to conclude, I would say that oxygen therapy is critical for the successful treatment of COVID-19 patient. Oxygen supply and best practices of planning the oxygen source and conservation strategies in the aspect of patient, device, and system. All guidelines can be made available in the system to facilitate the rational use of oxygen. These are my bibliography. Thank you so much.
Yes. Thank you. And Ambili is online. Ambili, you have any comments on the presentation? Yes, actually they pre-recorded the session, but due to audio issues, we were unable to show the recorded presentation. Over to Dr. Clara, please.
Thank you, Dr. Lata. I must thank Ms. Aditi and Ms. Ambali for their efforts. Actually, they have justified within the short time. May I summarize and conclude the topic on rational use of oxygen? Nurses can make a difference should be a hashtag, and certainly they can make a difference. That's what we are hearing from morning in the sessions. But how can they make a difference? We need to have a program like NOSP, NOSP, like oxygen stewardship, nursing oxygen stewardship program, which will have nursing sensitivity indicators, escalation, de-escalation, and how precise nurses are trained to capture and escalate and support clinicians. And there should be complete support from clinicians by empowering them and from the management. So when they, sometimes like when they over escalate, we have to consider that, because when we stop them, then they are stopped for good. So we have to encourage them, even if it is a false escalation or de-escalation, take that as an opportunity to learn. So empowerment is a key. And we could create a link nurse team across all the wards. Suppose we have 24 wards. Each ward will have, and each ICU will have one link nurse. They can be certified as an oxygen link nurse, and they can come together every month or week in the beginning, and then they can do some lean projects, which really helps other institutions like AIIMS and other wonderful institutions are there in India who are putting forth their efforts, like where I work as well. So what we could do is we can take up some projects, and this can be showcased so that other institutions can learn. We can learn from each other and participate in 11 clinical audits. This is a greater chance for nurses. Normally, when we see clinical audits, we don't see nurses coming up in the article or in their publishing part of the clinical audit. We have to give not only data collection, they have the right to be author in the outcome that they have developed. So we need to participate them right from the beginning to the end and include them in the celebration. And leadership coaching on governance pertaining to rational use of oxygen. So this is for the leaders in nursing. So we have to keep coaching them and we have to provide a climate to nurture these things. So with these few points that has come already from the speakers and whatever I have put in, may I conclude putting a general request to all of you, dear audience, and the leaders and the policymakers. Let us be sensitive in preserving Mother Earth and promote climate sensitive culture in our families, communities, and institutions we serve. Association of Nursing Institute of India, President Thankam, and the entire team of officials and the nurse executive members, we all work towards such a good initiative. And one such is like committing to support climate change prevention and safer healthcare. So with this, thank you, Dr. Lata, and thanks to AIIMS and Council and Ministry of Health for the greater opportunity. I'm privileged and honored. Thank you.
Thank you so much, Dr. Jyoti. That was excellent, and what an inspirational speech from you to all of our nurses and to the the nursing leaders that are here from our academic institutions, the policy institutions, and our medical institutions. So thank you again. And I know we appreciate, because we realize that there is no way we can get this done until all of us come together. There is no, unless the public, the private, the associations, the regulators, all bodies come together. COVID is not a pandemic that we are going to, any single person is going to try to take care of. It's not going to happen. We know it. It probably calls for us to work together more than ever. We are now, I also want to thank Ms. Aditi and Ms. Ambili for that excellent presentation. We are now coming to the last part of the session. Thank you again, Dr. Jyoti. We're going to come to the last part of the
Thank you, Kavita.
session.
Signing off. Thanks.
Thank you. We are coming to the last part where we have a panel discussion. So we will, so thank you all for staying back for a few minutes more. I think in about 15 or 20 minutes, hopefully we will wrap up, but this is some excellent discussions. So I would urge you all to please wait so that you can, there'll also be a last final Q&A moderated by Professor Devrari and Dr. Lata when they wrap up. So I'd urge you to please all stay back for the same for the next several minutes. We are very grateful to Madam Beenamma Kurian from St. John's, who's joined us as the Senior Manager and Accreditation Coordinator at St. John's. Thank you, Madam, for being here and for agreeing to chair this session. We, on behalf of Ministry of Health and Family Welfare, I will thank all of you for being here. And you have Madam Mamta and Ms. Matilda and Ms. Kiran, who are on the team. So I will turn it over to you without further ado. Thank you.
Yeah. Good evening and welcome to a panel discussion on cleaning, disinfection, and sterilization of oxygen delivery devices. As you know, this pandemic have hit without any warning, and we have landed up in a nation which is gasping for oxygen, and then a nation which is overflowing with the waste products from an oxygen therapy. So the need of the hour in such situation is how we can reuse, which are the way we can control the cost of oxygen therapy in hospitals. So with this, we have a team of expert members from AIIMS, which is going to throw a light on how the aspects of oxygen therapy, disinfection, and sterilization, and how we can control the cost on it. Now, let me over to Miss Matilda. Matilda, are you on?
Yes, ma'am.
Yeah. Matilda, how are we going to disinfect oxygen delivery devices in hospital settings? Can you throw some light on it?
Yeah, thank you, ma'am, for the opportunity. And as ma'am told, it's a very valid question regarding this disinfection, because not only the oxygen delivery system, it's also important to have an infection control method so that we can prevent the secondary infections and other complications which arise because of the due to the infection, disinfection of other oxygen delivery devices. So when we come to the
the disinfection of oxygen delivery devices. We have the different methods like cleansing, we have disinfection and the sterilization method, which is used in hospital settings. So cleaning is mainly the mechanical process of removing the dirts and inorganic materials which is on the surface of the device, and which is mainly done by rinsing with soap and water. And after once it is done, it is dried, and this is the cleansing method. Then we have the disinfection, which is used using chemicals and the heating process, so that we can remove the microorganisms which is live on the device surfaces. And then we have the sterilization method. That is, we are using low temperature method, especially the ETO sterilization. So that, and we have chemical methods also used. So that this is a very effective methods. Disinfectants, that is a chemical disinfectants infectants used in for oxygen delivery devices in hospitals includes the glutaraldehyde. That is the most commonly used high-level disinfectant, which is which is non-corrosive for the metals and other lens, which does not damage. And it should, as a health worker, preparation of glutaraldehyde is very important, because the many literatures have showed that the side effects and of the glutaraldehyde for the medical professionals has been noted, and the side effects has also noted. So it is very important to use proper PPE shields while preparation of the glutaraldehyde. And these solutions are coming with the activator, and the according to the percentage which is required and recommended, it should be prepared properly. And once it is recommended dose, which percentage which is used for glutaraldehyde is 2% or 2.5%, and it is prepared for 30. Disinfection is done for 30 minutes, and the preparation of the prepared solution should be changed every 28 to 30 days. And it, as a nurse, we are responsible for the changing of these solutions, so that further damage or any infection due to this disinfection solutions or proper methods or process which should be followed can be avoided. Then comes the then we have the isopropyl, 70% isopropyl alcohol, which is used, which is mainly used for the surface disinfection. And we have the basilol 25, which is used, which is mainly a quick, rapid acting non-aldehyde free disinfectant, which is also used for oxygen devices. Then coming to the devices which is used for oxygen delivery disinfection, mainly is the nasal prongs, and then we have the sterilization method, which is mainly used for the oxygen delivery devices are ETO sterilization, especially the ventilator tubings, ambo bags are sent for ETO sterilization, which is widely used low temperature sterilization method. And it can mainly, the advantage of ETO sterilization is it can be used for the items that are moisture and heat sensitive, and which cannot be sterilized using the steam sterilization. So if the facility is having a ETO sterilization, it is the best method used for the oxygen delivery devices. Then we have the devices, that is especially the nasal prongs and oxygen mask, which includes the simple oxygen mask and the non-breathing mask with the reservoirs. These are actually single interface devices, which should be only used for single use. So normally it should be discarded after each use, which is into the designated biohazard container. And if it is used continuously for the same patient, it should be changed every 24 hours. Then comes the other devices like ambo bags. Normally for each patient, especially in ICU settings, there should be an ambo bag separate for each patient. And after use, it should be cleansed with soap and water and dried and sent for ETO sterilization. But if a facility is not having a ETO sterilization, the other process for disinfection of ambo bags are like it should be disinfected after use. And if not used for any patients, it should be disinfected every 24 hours before, mostly in the morning time. And Then we have the for ambu bag. Once it is used, it should be cleansed with soap and water solution. We should remove all the bio load on it, and we have, as an ambu bag, we have to separate each part of the ambu bag: the self-inflating bag, the reservoir, the AB valves in it, and then we have the mask. These all should be separated and then immersed into the corsetic solution. Once the debris is removed and washed with solution water, we have to dry these ambu bags, because with the water we should not immerse into the glutaraldehyde solution, because it can also change the disinfectant property of the solution. So this should be immersed properly for 30 minutes and remove the parts, and then we have to cleanse it with a sterile water which is freshly opened. And this is also important because the disinfectant should not be there in the ambu bag. So it should be clearly removed, then air dry and kept for the next use. Then comes the oxygen hoods. Oxygen hoods are used for the pediatric patients. So this also, after use, we have to disinfect with soap and water, then dry with wash with sterile water, air dry and kept for the next use. Yes, ma'am. Then the other devices which is used for intubation, especially the laryngoscope. For in laryngoscope also, we have to remove the debris once it is used in running water. Then we have to dry it and then use Bacillol 25 to disinfect it. And especially the blades and the stillet should be dried, and then we should wrap it in a sterile pad so that we can use for the next use. These are the main oxygen delivery devices, disinfection which is used in the hospitals.
Thank you, Petilda, giving very clear concept on how to disinfect oxygen delivery system. It's very important for a nurse, because most of the time we'll end up in a huge number of devices without knowing how to go about with that. Now over to Ms. Mamta Chaudhary. Can I ask you how we know humidifier disinfection can happen?
Thank you, ma'am, for your question. Oxygen humidifier bottle, if are used, they need to be disinfected either daily, every 24 hourly, at a prefixed time. Especially in our hospital setting, we are doing it before 10 a.m. or at least by the 10 a.m. And they also need to be disinfected if the patient is getting discharged or if they get died down. Now the question arises how to disinfect them. So for that, you need to wash it up firstly with the soap and detergent and rinse it with clean water. After rinsing it, dip it in 2% of glutaraldehyde or Corsolec solution for at least 30 minutes. Then we can take it out of the solution and need to be rinsed with sterile water. So the main focus here is after dipping in the solution, you need to rinse it with the sterile water, air dry it and keep it in a sterile drape until you need to use it again. So when we are going to use this oxygen humidifier devices, we need always fill them with the sterile water. In any condition, tap water or filtered water should not be used. You might have seen.
Yes. Do you think we should use saline?
Normal saline also, ma'am, some of the researchers say it could be irritant. So it's always better to go with this sterile water. Okay. So you might have seen the humidifier, they have the maximum level and minimum level marking on that. So whenever the sterile water, it goes down the minimum level marking, we should discard the remaining sterile water and fill it with the fresh sterile water always. We should never try to top it up. And whenever we are filling it with the sterile water, make sure you are using the freshly opened one. So that's it about oxygen humidifier bottles, ma'am.
What are the methods we are using for ventilator circuits disinfection?
Okay, when it comes to disinfect ventilators, two things need to be taken care of. One is the ventilator circuit and second is the external bodies of the ventilator. So when talking about the ventilator circuit, we generally have two types of ventilator circuit, the reusable one and the non-reusable one. Most of the hospital settings nowadays are using non-reusable one only. So they are one-time use circuit. We need to apply them and we have to replace them with the new one every 7 days. But 7 days is not always the criteria. If you feel they are visibly soiled, we can replace them before 7 days also. Yes. And if we are using the reusable one, they need to be disinfected after at least every 72 hourly if they are being used for a single patient. And if we are switching on the patient, then once we are moving from one patient to another, they need to be disinfected. Now, how to disinfect them? We need to wash them with water and detergent first, rinse the detergent completely and dip them in 2% of glutaraldehyde or Corsolec solution for at least 30 minutes. Whosoever is disinfecting, they need to make sure that the disinfectant enter the lumen of the tubing completely. So once 30 minutes are over, we can take them out of the solution, rinse them again with this trial water, air dry them and keep them ready for the next use. As nowadays we are considering each and every patient as the infected one, so we need to be very particular. Whosoever is disinfecting, they need to wear proper PPE while disinfecting these devices. Then coming to the external surfaces of the ventilator, we need to clean it first with the soap and detergent, making sure that we use minimum amount of water, as this is an electrical appliance and we may ruin it by applying more amount of water. Electrical circuits should need to be considered. They should be kept away from the water which we are using. Then we have to dry them with a dry cloth, and then with some compatible disinfectant, it need to be disinfected. Now, what do we mean with this compatible disinfectant? This most of the time, the device manufacturer, they provide us with the guideline that our ventilator need to be disinfected by this thing. So we can use that. Otherwise, in hospital setting, we are using ethanol 70 to 90%, hydrogen peroxide or sodium hypochlorite to disinfect these ventilators.
Okay, that is very vast information. I'm sure the hospitals are going to be appreciating this. Now, what about the suction tubings and pulse oximeters? Use of pulse oximeter is now, even in a household, we use pulse oximeters. So how we can clean this or disinfect this?
Okay, ma'am. Firstly, coming to the suction tubing, these are very similar to ventilator circuit, as these are also reusable one and a non-reusable one. So if we are using non-reusable one, after every single use, they need to be discarded down and replaced with the new one. But if we are using the reusable one, they need to be disinfected after each patient use. And the process is very similar how we have discussed to disinfect the ventilator circuit. We need to wash it with the soap and water, dip it in glutaraldehyde or Corsolec solution for at least 30 minutes. Again, rinse it. And next, coming to pulse oximeter, in an ideal situation, every patient should have their individual pulse oximeter. But if condition don't permit it, and we have to use the same pulse oximeter for more than one patient, whenever we are switching pulse oximeter in between patient, we need to disinfect them. So for that, we need a fresh cloth or some disposable wipes that are dipped in again compatible disinfectant, which could be sodium hypochlorite or ethanol. Most of the time we are using ethanol 70 to 90%, which is also known as spirit. So it should be cleaned from top to bottom. All the sensors should be properly cleaned. And again, as it is an electrical device, we need to make sure that too much of fluid contact should be avoided.
Thank you very much. Now over to Kiran Rajput. What is the disinfectant methods used for HFNC?
Thank you, ma'am. And now, as we have seen that in this pandemic time, the use of HFNC device has increased. So the cleaning and disinfection is a major concern. So for first of all, like ventilator setting itself, we have to clean ventilator device. Like first, it has an outer surface and the accessories. The accessories are usually single patient use. So after use from one patient, we have to dispose of all the accessories like the tubings, the nasal prongs, the water chamber, humidifier chamber in a designated biomedical waste bin. And coming to the main this device, first with the soap and water soaked cloth from top to bottom, let it dry, and then again with a disinfectant solution, preferably it can be alcohol-based disinfectant solution. In the same manner, we have to clean from top to bottom. And for high-level disinfection, we have to follow the manufacturer's guideline, like they do thermal disinfection. It is inbuilt disinfection method in the machine itself. We have to follow the manufacturer guideline how to do the thermal disinfection.
sometimes in some conditions, if we have to reuse the tubings, we have to follow the same like the ventilator tubings. First, we have to clean it with soap and water, disinfect in the 2% glutarate solution for 30 minutes. Then we have to rinse with sterile water, then dry it, and then only we can use. But ideally, we have to use single patient use only these devices. And that is how we can do the disinfection and cleaning of the HFNC devices.
That's good. What about nebulizers and spaces? Can you give a little input on this?
Yes, ma'am. These nebulizers, as we are using, we know that these nebulizers, the ultrasonic nebulizer, it has 3 parts: the nebulizer tubing, the medication cup, and the water reservoir. Ideally, these all should be a single patient use only. And coming to the nebulizer tubing, it has to be disinfected in every shift. The nebulizer cup has to be disinfected after each patient use, and the water reservoir, that it has to be cleaned and disinfected every 24 hourly. Coming to the nebulizer tubing, if it has to be first cleaned with soap and water, then we have to dip in a disinfected solution, preferably 2% glutarate for 30 minutes. We have to ensure that the solution, it enters the lumen for proper disinfection. Then remove from the disinfectant solution, we have to rinse it with the sterile water, hang it in a clean area for drying. And proper drying is a must, because after proper drying only we should use the nebulizer tubing. Coming to the nebulizer cup in which we fill the medication, we should ensure that the residual medication should not be left behind and used for next use. Every time we use the nebulizer cup, it has to be cleaned and disinfected. And how we do it is the same. We have to wash with soap and water. Then again, we have to dip it in 2% glutarate or disinfect any disinfectant solution as recommended by the unit. And then again, we have to rinse with sterile water, dry it properly, air dry it, and then we have to use for the next use. Coming to the water reservoir where we put the sterile water, it has to be cleaned every 24 hourly. There is a tube, small tube behind the nebulizer. From that tube, we have to drain the water and clean that area. The tube can be also be cleaned with a brush to remove the debris, and that is how we clean the nebulizer. And the spacers.
I could see the practical experience what you are sharing here now. Now my question is to Mamta. Can you throw some light on how to disinfect this oxygen concentrators? Now the use of oxygen concentrators is very much in all hospitals. So please.
Ma'am, this is Kavita here. I'm going to request you all to please be brief because we have got a lot of comments. So please, we need to really close this session. So request you to keep your comments very brief. Thank you.
Okay. Thank you.
Okay, ma'am. Generally, the oxygen concentrators nowadays that are available, they all have disposable patient interface, nasal prawns, and water chambers. So they need to be disposed of as per the manufacturer's guideline. Second thing, the oxygen concentrator have this oxygen moisturizing filters, which we have already discussed how to discard them. The major consideration we need to take here is the air intake filters that need to be periodically assessed and replaced. So one should periodically assess them at least 1 to 2 times per week for any accumulation of dirt in them. If it feels like the dirt has been accumulated, it need to be taken out, dipped in soapy water, and then it can be rinsed with plain water to make sure all the dirt has been rinsed, and then it can be dried in a shadow area and reused. They also have the bacterial filters which need not to be washed, and they had to be replaced periodically as per the manufacturer guidelines. Thank you, ma'am.
Thank you. Thank you all once again for this very clear explanation on how to disinfect oxygen therapy devices. I'm sure the nurses are going to get benefited of it. What I wanted to insist here is that keeping all the oxygen devices dry before disinfecting or before doing anything, you have to clean it with soap and water and dry, then use any type of disinfectant method. So as a parting note, I must thank the Ministry of Health, Ma'am Leda and Ma'am Kavita and the rest of the AIIMS team for arranging this fantastic team. Please do remember, oxygen is very expensive in hospitals, but very free in our environment. So it's our responsibility to ensure oxygen is available in our earth, preserve our earth, maintain green initiatives. And thank you very much. Good day, Jai Hind. Thank you very much.
Thank you so much. Thank you, Madam Beenama Kurian. Thank you again. And I know at St. John's, you'll do brilliant work. To all the great institutions that are here today that have joined us, all of the leadership, I'm actually going to just wrap up and turn it over for the final words to Professor Deorari and to Madam Lata. Thank you again to the three panelists. You all answered the questions really beautifully. We have received a lot of private messages from people appreciating this, style of the presentation. The AIIMS faculty as well as the Indian Nursing Council have put in a lot of effort to ensure that this is, coming together so well. So I will just, on behalf of the Ministry of Health and Family Welfare, thank you all once again for staying through 3 hours. Dr. Deorari has reminded me we're at 3 hours now. 3 hours on online is not a joke, during all of this. I am sitting inside a quarantine room and doing this, but I'm so used to doing it now, we don't even care because, it has become a normal for us. But to all of you, thank you for coming out and saving lives every day. Dr. Deorari, over to you, please, and I will stop.
Thank you, Kavita. All those nurses champions who have joined today, as you hear from each one of us, you are the key person who is 24/7 bedside for the patient. And you are real oxygen stewards who can make sure that we are able to implement rational oxygen therapy. We all know, we have been talking, oxygen is like a drug. We need to have a prescription, when to de-escalate, when to hike, what type of devices to be used, what flow rate has to be used. And above all, make sure patients don't get infection while we give oxygen. And you learned about how to make sure to take care of your equipments, humidifiers, and the devices which are going to be used for patient care. We also heard a lot about audit teams. Very important. Nurses need to make audit teams, and we need to have nursing leadership on board. We need to have the MS on board, the leadership of hospitals on board. My request to all the hospitals is kindly make SOPs and protocols for making sure how you are going to keep your equipment sterile, how you are going to use oxygen therapy, because these SOPs and protocols have to be used by each and every member. You have to sit with your doctor, with your team of nurses leadership, and come out with something which are doable and simple to understand and apply. So at the last, I would say, I think this is a wonderful initiative by Ministry of Health and Family Welfare. And on behalf of my director, Randeep Guleria, we missed him today because he was busy somewhere else for an important task. In addition, Indian Nursing Council, Trained Nursing Association of India, all the leaders who joined, all the faculty members from AIIMS, all the nursing colleagues from College of Nursing under leadership of Lata, who made this as a teamwork. As I said, more than 3 hours logging in for a webinar is not an easy task. But I am so happy that for the first time I saw, Kavita, more than 10,000 nursing colleagues joined for this webinar, which is on YouTube. And I hope you are going to tweet this on Ministry of Health website. And I would request each one of you to kindly log on to Diksha iGot platform. All the resource material and PowerPoint slides which are shown are there. You can earn certificate also for completion of lesson if you take the MCQs on iGot Diksha platform. So my best wishes, and hopefully we won't see much need for oxygen with the Omicron wave 3 in times to come. So thank you so much. Thank you, Lata, for organizing this wonderful webinar. Thank you so much.
Is thought by nurses as a very simple procedure, but COVID has really given us opportunity to explore in detail. I think this platform everybody was asking very specific questions. This simple procedure has got so many doubts for the nurses to clarify, and they are really looking forward for a platform where they can interact with the experts and gain their wisdom and implement in their settings. I think it is worth repeating the same session, I feel, because many questions are really flowing in the chat box, and due to time constraint, we are unable to answer all of the questions. And this program was possible, and I attribute the success to Dr. Devrari, the professor and HOD of pediatric department, because any program he does for the medical fraternity, he always thinks of the nursing fraternity and handholds us and elevates us and gives us opportunity to get empowered. Thank you very much, sir. And I must thank Kavita for really motivating so many nurses across the country to participate in the program. I think this is the first time it has happened that so many nurses are participating in the event. So thank you, Kavita. We look forward for more such events in future. I think this is just a beginning, and we have a long way to go, and we can empower nurses with many more practical aspects of nursing care, not only oxygen administration. And I must thank Indian Nursing Council and presidents of all the association for making this program spread across all the nurses and encouraging us to host this program. So I am thankful to the President of Indian Nursing Council and Secretary of Indian Nursing Council especially. And I must thank all our faculty members, over a short span of time. They have worked so hard to coordinate this program. Without them, this program would have never been successful. And we have AIIMS nurses who have the practical wisdom to share with us. So I think this kind of approach has made this program very successful, having the medical faculty, nursing officers, and the support from Ministry, Indian Nursing Council, and various associations. Thank you so much from the bottom of my heart. And we wish to meet again in many forums with much more important themes for nursing care. Thank you, sir. And thanks, Kavita, and thanks all the chairpersons and resource persons.
So, Lata, if we can make 2 pages with all the questions which are there with 3-liner answers and circulate to all the participants, that will be great. Because there are many questions in the chat box which we have not answered.
Definitely, sir. We will do that.
Yes, sir. And we will take care of it. Thank you, sir. Thank you all. Thank you all to everybody. We have more than 11,000 people that logged in today at our final count. Thank you to everybody. And if you are on Telegram, we have put on a link for Telegram. You may please also join through it. We can actually be talking to each of the faculty are all there, and they'll be able to answer a lot of these questions live. So we will be getting with you separately. We will be sending you emails on it as well. Thank you all so much. Have a good evening.